is here, everything's fine. So,
Great, thank you.
so how is your evening?
Yeah, it's quite nice. Yeah, just used the pool and the gym and trying to find some sleep. I have two young kids at home, so
Right, yeah. So then the contrast is
yeah.
amazing. How old are they?
4 and 1.
Fantastic, fantastic.
Well,
Congratulations.
thank you.
Congratulations. I have also two. They are now
Yeah.
11 and 14.
Oh wow.
And it's fantastic. It's the goal of my life.
Yeah. No, it's
It gives so much pleasure and
it's
satisfaction,
obviously a big
everything.
priority, isn't it?
Yesterday I thought there is a spotlight on one of the places here that is unneeded. I will try to fix
Yeah,
it
yeah.
maybe. Okej. Dzień dobry. Witam wszystkich Państwa serdecznie w tym wspaniałym dniu, drugi dzień neurologii. Mamy bardzo dobrego wykładowcę, pan dr Matthew James, specjalista Europejskiego College'u Neurologii Weterynaryjnej z Wielkiej Brytanii. So Matthew, today we are going to talk about the balance in life balance, work-life balance, or only balance?
Just balance.
Okay, good. So the floor is yours.
Hello. Thank you once again for the introduction. My name is Matt. I'm a neurologist. I work at Weir Referrals in the northeast of England. Happy to be here in Łódź, which I hope I'm now pronouncing almost correctly. Happy to see so many of you at the neurology stream. I've got a few different talks today, so hopefully there's something of interest for everyone. But this first one, as you know, is on a balancing act, so approach to vestibular dysfunction in dogs and cats, which is quite a common presentation both to neurologists and to primary care vets. So in terms of our, stop working, there we go. Just a quick agenda. So I'm going to start just by covering some anatomy because I think that helps to interpret some of the clinical signs we see. And then we're going to move on to the clinical signs with vestibular problems, and then finally look at some of the main differential diagnoses for these diseases. So just to start with some anatomy. So the vestibular system has two main parts to it. It has a peripheral part and it has a central part. So the peripheral part that you see here in red consists of the labyrinth. The labyrinth is both a membranous and a bony structure contained within the temporal bone, sits adjacent to the tympanic bulla. And so it has several parts to the labyrinth. So we have the semicircular canals, we have the vestibule, and we have the cochlea. And the cochlea is mostly involved in auditory function, whereas the semicircular canals and the vestibule are the main vestibular organs. And then coming off the back of that, we have the vestibular cochlear nerve, which then travels through the temporal bone towards our central component, which is the vestibular nuclei. So we have, within the brainstem, we have 4 vestibular nuclei on each side of the brainstem. So those neurons from the vestibular cochlear nerve synapse in the nuclei, and then our next axons travel to all sorts of areas of the central nervous system. They go to the forebrain, the cerebellum, down the spinal cord, and basically that all functions together to give us balance. So it's a bit like a set of scales, so that system is repeated on both sides. And under normal circumstances, if both vestibular organs are functioning normally, then it's like a set of scales. So there's equal input from both sides, and that allows the animal to maintain balance and equilibrium. And this is how we see it on MRI, on CT. Sorry, down here. So we have those components here. So obviously the tympanic bulla, and within this area here would be our vestibular cochlear organ. And that's in a cat, so they have quite a prominent tympanic bulla. So normally the vestibular system is always active, so we're getting constant input from both sides, telling us where our head is positioned, telling us how to position our body. And so the overall effect is, maintaining that balance and the equilibrium. When we get a lesion of the vestibular system, generally the input decreases, or the input is absent. So what happens is the normal side is still inputting that information. And because the vestibular system tends to activate the extensor muscles of the limbs, the animal is almost pushed towards the abnormal side. So we get, again, if you think about that set of scales, if you get a lesion on one side, it tips towards the affected side. So generally, in most cases, and that's the extent of my technology knowledge, so the animal will tip towards the side of the lesion, and that's why we get quite an extreme head tilt in this case. Slide. And so there are generally a set of clinical signs that occur in most cases of vestibular dysfunction that are common to both the central and peripheral components. And that's what we're going to look at now. So these are the signs you might see with a lesion of the vestibular system, regardless of whether that's in the tympanic bulla, the vestibular cochlear nerve, or centrally within those vestibular nuclei. So firstly, we might see an abnormal stance. So obviously these animals are very off balance, and so they kind of hold themselves differently. They might be reluctant to walk. Classically, they have a wide base stance to sort of maintain themselves upright and to lower the center of gravity. And as I say, they may be reluctant to move because they anticipate that they might fall or roll to one side. When they do walk, we often see ataxia, and so there are three types of ataxia. One is vestibular, which is the focus of this lecture, but we also see cerebellar ataxia and proprioceptive or spinal ataxia. So vestibular ataxia, as in this video, is characterized by leaning, falling, sometimes rolling. So this dog has a left-sided vestibular lesion, so obviously you can tell there that very off balance, stumbling to the side, also has a head tilt to that left-hand side. And then sometimes it can be more subtle than that. So if it's safe to do so, you can try to sometimes cover the eyes of these dogs, or even blindfold these patients if they would tolerate that. And that can exacerbate the clinical signs to the point where it then reveals itself, because the visual function allows almost to compensate in some cases. So if you remove that, it can make the vestibular signs worse, and then that might be important in some cases to help with your evaluation. And then another sign is head tilt. So obviously this is when the head is rotated around the long axis of the body, such that one ear is held closer to the ground, different from a head turn, which the head is obviously turned to the side, but the ears are held level. So watch out for that. Again, in those quite subtle cases, I would recommend to look at the animal directly from in front with your eyes level with the patient, because sometimes it's again a lot more subtle than in these cases here. And again, usually that's directed towards the affected side, although we're going to see there are some exceptions to that. We will sometimes see involuntary movement of the eyes called nystagmus. So nystagmus is a rhythmic movement, usually with a slow and a fast phase. We characterize it as either spontaneous, which means that it's occurring at rest, and we don't have to do anything to exacerbate that, or positional, in which when we move the head into a certain position, we then start to see the nystagmus. We can also classify it according to the direction. So it can be horizontal, it can be vertical, or it can be rotatory as well, or a combination of those three. And this is a French bulldog, which we later diagnosed with otitis media interna, extending into the cranial cavity, which is quite a common condition we see causing vestibular disease. So you'll see that this dog has a head tilt to the right side. It has a spontaneous horizontal nystagmus, and if you can hopefully see, the slow phase is to the right side, which would give us a localization of right vestibular system in this dog. So try and remember that as almost the lesion tends to slowly drag the eyes back as they try to escape, and then they slowly get dragged back in. So the slow phase is generally towards the side of the lesion. And another thing to look for in the eyes is strabismus. So this is when the eyes are more deviated, so they're not held in the normal position. So this isn't an involuntary movement, but it's an involuntary position of abnormal position of the eyes. And sometimes, again, it's only in certain head positions we might see this. So always kind of, change the position of the head in these patients to see if you can reveal something that wasn't there before. The classic thing in vestibular diseases is that we get a ventrolateral strabismus, as in this dog. So you can see that the left eye is deviated downwards and slightly outwards, and that's only when the head is raised upwards, and that's, in the textbooks at least, the most common type of strabismus we see with a vestibular lesion. So those are all signs that can be common to any vestibular lesion, as we said, either peripheral or central. In terms of how we try and differentiate the two things, there are some things we can look for, starting with peripheral lesions. So again, this is lesions in the tympanic bulla, the vestibulocochlear organ, or the vestibulocochlear nerve. So with peripheral lesions, we will sometimes see Horner syndrome. So Horner syndrome is a term used to describe a group of clinical signs that occur when we have disruption of the sympathetic nerve supply to the eye. So in this dog here, the left eye, and basically everything gets smaller. So the pupil is small, miosis, the eyelid droops down, ptosis, the eye sinks back into the orbit, enophthalmos, and as a result, sometimes the third eyelid will passively protrude over the eye once it sinks back into the orbit. So you can see most of those signs in the dog here, up here, although the pupil's not so visible due to the third eyelid. And we sometimes also see facial nerve dysfunction, cranial nerve 7, and that can cause facial paresis or full paralysis. So this dog has a right-sided facial paralysis. We've got drooping of the facial muscles. So the facial nerve supplies the muscles of expression around the eyes and the face. So drooping of the eyelid, drooping of the muzzle on the right side. Because it also supplies our blink reflex, we might not have a palpebral reflex. So if we touch the right eye of this dog, it may not be able to blink. And also we can get a neurogenic keratoconjunctivitis sicca or dry eye. And the reason for that is the facial nerve provides parasympathetic innervation to the lacrimal gland. And so these animals are at risk of corneal ulceration. And so always worth staining the eye in those dogs. And the reason that those things are more common with peripheral vestibular disease is that both the sympathetic nerve supply to the eye and the facial nerve pass within the region of the tympanic bulla or the vestibulocochlear nerve. So the facial nerve, for example, shares quite a common pathway through the petrous part of the temporal bone in the skull. And so if we get lesions, for example, an infection within the middle or inner ear, that's why we can get involvement of those nerves. With central lesions, we can spot different things. So this is diseases within the brainstem, within the hindbrain. So the characteristic of the nystagmus can help with this a bit. So a nystagmus that's vertical is described as more likely to be a central disorder. Sometimes that should be interpreted with caution, because what looks like a vertical nystagmus can actually be slightly rotational. And so it's sometimes quite difficult to spot what is a true vertical nystagmus. You can see in this video here, hopefully, a vertical nystagmus. So exactly the same, that we have a slow phase ventrally, which obviously doesn't really help with lateralizing the lesion, but perhaps what's more relevant or easier to spot is a nystagmus that changes direction. So if you have a dog that has a horizontal nystagmus, you lie the dog on its back, and this applies to cats as well, you lie the patient on its back, or you change the head position and it becomes vertical or it becomes rotational. That change in direction is more consistent with a central disorder. Postural reaction deficits, or, well, proprioceptive deficits. So this is probably the single most reliable indication of a central vestibular disease, of course, alongside vestibular signs. So the way we test these, as I'm sure you'll do quite commonly, is firstly the proprioceptive placing, where we take the foot, we turn it onto its dorsal surface, and we expect that that should be replaced almost immediately. And the other way to test it is the hopping response. So to try and have the animal on one limb, or if in larger dogs, sort of hold up one side, slowly push the animal to one side, and they should be able to maintain a balance. The limbs should come out to the side and stop the animal from falling. And so those are the ways we test for postural reactions. And if we have slow reactions on one side of the body alongside vestibular signs, that would indicate usually a problem in that region of the brainstem, because we wouldn't expect that to happen in purely peripheral disorders. And sometimes we can look for other cranial nerve abnormalities. Obviously, we have 12, mostly coming from the caudal part of the brain, the brainstem. Obviously, the one caveat to that is if it's only the facial nerve, as we've already said, that would be more likely peripheral. But if we see other cranial nerves involved or combination, we start to worry about central disorder. So that can include trigeminal nerve, which supplies our masticatory muscles and our facial sensation. Abducens nerve, which is a small nerve where we would see a medial strabismus. Again, the facial nerve. Our glossopharyngeal, vagus, and accessory nerves kind of contribute to mainly our ability to swallow. So if the animal has dysphagia or an abnormal gag reflex. And our hypoglossal nerve, which supplies our tongue muscles. So an example of this is here. So this was a older Staffordshire Bull Terrier that came in. Firstly, we can see the head tilt to the, well, it's not the most marked, but it did have a head tilt to the right side. So we can tell already that that dog has a vestibular dysfunction. We see atrophy of the temporal muscle on the same side. So that's our trigeminal nerve, cranial nerve 5. It had a dilated pupil on the same side. And if we shone a light in that eye, it had an inability for the pupil to contract, which suggests, in this case, an oculomotor nerve dysfunction, cranial nerve 3. It had a relatively subtle but slightly drooping muzzle on that same side. Again, facial nerve, cranial nerve 7. And also what's quite nice is, because you don't see that too often, is atrophy of the tongue muscles on that same side. So the tongue was deviated and, sort of muscle wastage on that side. So that would suggest our hypoglossal nerve or cranial nerve 12. Unfortunately, I don't have the MRI for this dog, but it did have basically what we suspected to be a tumor along the base of the skull, involving, as you can see, multiple cranial nerves. So we know that that animal doesn't have a peripheral disorder because there would be, assuming everything links together, there's no way that we would get all those cranial nerves involved in a lesion of purely the middle or inner ear. We can also look for abnormal mentation, because obviously if we have a central disease, it tends to be in the region of the brainstem where we get quite commonly other neurological signs, particularly abnormal mentation. So that can range anywhere from obtundation or dullness to all the way to coma, so not responsive to even painful stimuli. Although be aware if the animal's obtunded or mildly depressed, that can be, you know, if they have a middle or inner ear infection, they're likely to be painful or sort of maybe nauseous. So sometimes you have to be a bit cautious about interpreting that too much. And this was a dog that presented comatose, which when we looked at the eyes, it had vertical nystagmus. It also has something called hippus, which is quite interesting, which is like a fluctuating pupil size, which can occur with different things. But yeah, so that dog had a quite severe lesion on the brainstem, causing nystagmus, vestibular signs, progressing to coma. So as with everything, there are a couple of exceptions to those general rules to just be aware of. One is bilateral vestibular disease. So obviously we've mainly talked about lesions on one side. With bilateral disease, it's almost like the scales can still be balanced, but we're not getting the input from either side. And so it can actually be less obvious because sometimes we don't get those lateralized signs. We don't see head tilt. We don't see falling to one side. More often, these animals are just very reluctant to walk because their balance is completely off. You might see wide head excursions when the animal turns the head to the side. It's almost that it goes too far, and it can't kind of stop itself. This is more often seen with peripheral disorders. The most common cause would probably be a bilateral otitis media interna. The reason we don't tend to see it with central vestibular diseases is because to have a lesion that is impacting both sides of the brainstem like that probably will have much more severe neurological deficits. Like that animal may well be semi-coma, comatose. One exception perhaps to that to be aware of is, which is quite rare, but thiamine deficiency in dogs and cats. So for example, in cats fed a mainly fish-based diet, if they have thiamine deficiency, that can target the vestibular nuclei, and we can get a bilateral vestibular disease in that case. And the other main exception is something called paradoxical vestibular disease. So this is generally occurs with lesions in a specific region of the cerebellum or the cerebellar peduncles, which attach the cerebellum to the brainstem. And the reason for that is the cerebellum is involved in the vestibular system and normally provides an inhibition to those nuclei. And so if we get a lesion in that specific part of the cerebellum, it might actually mean that the nuclei on that side are more active, and therefore we get a head tilt away from the side of the lesion. So the dog tilts towards the normal side. And the way to look for that is when you test those postural reactions, those should always be on the same side as the lesion. So if the dog's head is tilted to the left and it's got proprioceptive deficits on the right, it's a right-sided vestibular lesion generally. And so those are the signs to look out for. Obviously, all those things can occur almost regardless of the specific diagnosis. So we're just going to look at some of the more common conditions we can see with this. So this was a study taken from the vet record in 2021, which is quite a nice study looking at 239 dogs presenting with vestibular syndromes, mainly looking at basically what those dogs were diagnosed with and which factors were important to look out for. And the take-home thing from that, again, this was a UK-based study, but the take-home, thing from that was that 95% of these dogs were diagnosed with one of 8 conditions. So actually, not that many really that compromise most of the vestibular diseases we see. And so we're going to go through those just one by one, really. So Number one is idiopathic vestibular syndrome, which I'm sure you're all familiar with, which is an acute onset peripheral vestibular disorder, usually affecting older dogs, can affect cats, and the age range in cats tends to be more variable. It's, as I say, probably the most common vestibular disease we see, and yet we still don't really know the exact cause for this. There are some theories as to whether the endolymph, which is the fluid within that within those semicircular canals, the vestibule, whether there's a disruption in that fluid. We do, so similar to Meniere disease in humans, perhaps you get a low-grade autoimmune inflammation of the vestibulocochlear nerve, vestibular neuritis, or perhaps a sort of temporary dislodgement of the we have tiny little stones within that fluid called otoliths, which in humans is described can become dislodged. So the important thing with this syndrome is that the prognosis is generally quite good, so most patients will improve initially within the first 48 hours and then generally resolve over the following weeks. Sorry. And sometimes we can get, although prognosis is good, we might get mild clinical signs that persist, for example, a head tilt or mild ataxia in the long term. And usually they don't require any specific treatment, but probably most commonly we're giving antiemetics such as meropenem or ondansetron in these patients. So this was a study in Frontiers from a couple of years ago looking at, so basically a survey of neurologists from a host of different countries, looking at what methods they were using to diagnose idiopathic vestibular syndrome. And these are mostly things to rule out other causes because it's a diagnosis of exclusion. And you can see the most common things there. This is in dogs specifically, this one. Generally, myself and probably in our hospital, those are the main ones we're doing in most cases. So obviously, full neuro exam. Generally, we'll do MRI scan, although depends on the client's situation. But routine blood work, CSF tap, including blood pressure, otoscopy, and probably a thyroid profile as well in dogs because hypothyroidism can cause neuropathies such as and cause vestibular signs. And then they sort of did the same in cats, and it was very similar, really. Most of the things were the same. Probably the main thing we include as well is we generally would test FELV and FIV to see whether we have an immunocompromised animal. So yeah, those are what we would tend to recommend. And if all of those were returned as unremarkable, then generally we would be left with a diagnosis of idiopathic vestibular syndrome in most cases. The second most common condition is otitis media interna. So obviously an infection in the middle and the inner ear, so the inner ear being our vestibulocochlear organ. And this can occur from direct extension from the external ear canal in dogs with otitis externa, from the nasopharynx via the auditory tube, or from a completely separate area of infection through hematogenous spread. And these patients tend to be younger than those with the idiopathic syndrome. They might also have the concurrent Horner syndrome or facial paralysis for reasons we mentioned earlier. And treatment generally involves systemic oral antibiotics for a minimum of 4 weeks and often a bit longer, ideally based on culture and sensitivity if we have it. That can be through myringotomy. Sometimes if we've had an extension of the infection, it will change from, well, it will start as a peripheral disorder. It will spread into the cranial cavity around the brainstem, and almost then we may get central signs. And so sometimes we might take CSF samples as well for a culture in those cases. And sometimes we might consider surgery. So, for example, a ventral bular osteotomy in severe or recurrent cases that don't resolve with medical treatment. And this is an example of that. So you may have seen this if you were here yesterday for the inflammatory diseases, but this was a Maine Coon cat, I think around 4 years old, that presented with vestibular signs. It has so it had relatively mild vestibular signs for several weeks, and then presented for an acute deterioration over a few days. And probably what had happened is they'd started off as a peripheral vestibular disorder with the infection in the tympanic bulla, and then at some point we've had an intracranial extension, and we can see when following contrast on the MRI scan, it lights up that side and of the tympanic bulla here, and then we have all this abnormal material sitting adjacent to the brainstem as like an empyema, so a collection of pus within the cranial vault. And we were able to sample that through a myringotomy. Culture revealed a Pseudomonas infection, and so we treated appropriately, and the cat did improve for a while. I think later on we had a recurrence, and then at that point we were recommending surgery. I don't think the owners went for it in the end. Next condition is meningoencephalitis of unknown origin, or MUO, which we mentioned yesterday as well. So if you were here, you'll have seen that as well. So this is a kind of an umbrella term to encompass 3 different specific conditions called granulomatous meningoencephalitis, or GME, necrotizing meningoencephalitis, NME, and necrotizing leukoencephalitis, NLE. And they share lots of similarities. They are inflammatory conditions that predominantly affect the brain, which can include the brainstem and the vestibular nuclei. We suspect that they are immune-mediated conditions with a genetic predisposition. So they're more common in smaller breeds of dogs, such as Yorkshire Terrier, Pug, Shih Tzu, Lhasa Apso, but they can occur in any breed of dog, and also cats, although much less commonly. And we might get vestibular signs by themselves or with other neurological deficits, because often these cause multifocal inflammatory lesions. So that can include, just as for example, blindness, circling, epileptic seizures if we have forebrain involvement, for example. And so GME, which is one of those, has several classic distributions. As we say, generally it's a multifocal disease involving multiple regions of the CNS. We can get a focal lesion, which is why we refer to it as granulomatous, because it can form a granuloma, which, if it were in the brainstem, could cause a central vestibular sign. And we do have an ocular form, which specifically targets the optic nerves, referred to as optic neuritis. So this was a Shih Tzu that presented with right-sided vestibular signs. And on the MRI, we see that we've got these kind of ill-defined, patchy, hyperintense lesions within the occipital lobe here, but also the cerebellum, which sits here. And this is part of our brainstem around the sort of region that we would expect to find the vestibular nuclei. And when we took the CSF, we found a predominance of mononuclear cells, small and large lymphocytes, together giving us a diagnosis of MUO. And obviously we then start generally on immunosuppressive treatment. Next on that list is a brain tumor. So there are a multitude of brain tumors that could, in theory, cause vestibular signs. We can see, most commonly we see primary brain tumors, so ones that are confined to the brain and don't spread to or from elsewhere. Those include meningioma, glioma, and ventricular tumors. So the fourth ventricle is adjacent to the vestibular nuclei, so ventricular tumors, things like choroid plexus tumors or ependymoma. And we also occasionally see secondary neoplasms that have metastasized from elsewhere, so the most common probably being hemangiosarcoma, lymphosarcoma, carcinoma. And the prognosis is obviously very variable, depends on the location, the size. Generally quite poor, because if we have a tumor in the caudal part of the cranial cavity around the brainstem, it tends to be less accessible with surgery, or perhaps more risk of radiation generally. So But yeah, depends largely on what we see there. So this dog had a meningioma. It's a slow-growing kind of extra-axial mass, so it comes from the outside and puts pressure on the brain, compression on the brain. And this one was quite nice, actually, because you can see that anatomy we talked about earlier quite nicely. So this is our, on the MRI, this is our cochlea here. Looks like a little snail, full of that hyperintense fluid. And then you can see, actually, going across that tumor, the vestibulocochlear nerve connecting to that part of the brainstem, which is severely compressed. And meningiomas tend to contrast enhance really well on MRI. We see brain infarct or stroke. And these dogs, I mean, it may be that in the past, sort of when we were doing MRI less, that a lot of dogs with idiopathic vestibular syndrome may have possibly had brain infarct because they present very similarly, tend to occur in older patients. In about half of cases, we find that there's underlying systemic health problem. And so generally we get an acute onset, non-painful vestibular signs that tend to improve as long as we don't have more than one infarct. So yeah, clinically can look very similar to the idiopathic disease. And those underlying causes can include things such as hypertension, hypercoagulability, thyroid disorders, heart disease, infections, neoplasia, so all sorts of things. So we will generally work up these patients to look for those sorts of things. And this is an infarct on MRI that was causing vestibular signs. So we see this kind of very well-defined segment of hyperintensity in the cerebellum, and not really causing any distortion to the anatomy itself, sort of compression or anything. And again, these changes here are most compatible with an infarct of the rostral cerebellar artery, which is the most common, I believe, location in dogs to have a brain infarct. Empyema we've already kind of mentioned with if we get, for example, an intracranial extension of an otitis, that would cause an empyema. The location of that infection is, can be again from local extension, secondary to direct trauma, spread from elsewhere, or even following surgery of the sinuses or craniotomy, for example. This cat here on this MRI was bitten on the head and developed an abscess on the top of the head, but then later on actually developed an abscess around the hard palate and had this very large abscess, empyema, ventral to the brainstem. And so one of the signs that we saw with that was vestibular signs. Metronidazole toxicity is one to be aware of. So this was on that list and causes generally a central vestibular dysfunction, central vestibulocerebellar dysfunction. In this particular study of 26 dogs, so the median dose was only 21 mg per kilo twice a day, which actually isn't that high really. But so any patient presenting with vestibular signs, we will tend to ask, obviously, what medication have they been on? If they're on metronidazole, it might be worth stopping that, and the prognosis tends to be good if it is stopped. Usually we'll give diazepam alongside it because it's been reported to help the rate of recovery from that. And the final one on that list, so this is like 95% of vestibular disorders we see, is a tumor of the middle ear. Generally not so common in dogs, I would say. More often in cats, so the most common malignant middle ear tumor in cats is squamous cell carcinoma, but we also see ceruminous gland, adenocarcinoma, lymphoma, fibrosarcoma, osteosarcoma. They can also get benign nasopharyngeal polyps, so overall the most common mass lesion of the middle ear in cats. In those cases, usually most cats are, I would say, less than 2 years old. And can arise primarily from the middle ear or sort of track up the auditory tube from the nasopharynx. So yeah, performing otoscopy and sometimes myringotomy, we can occasionally collect samples for diagnosis. And usually, if the tumor is confined to the middle and inner ears, in most cases, a ventral bular osteotomy is preferred. So I hand those over to soft tissue team. So that's, I think, where I conclude this talk. I hope that was okay. If you have any questions, please let me know.
Thank you very much. You're always perfect on time. Thank you, yeah. Fantastic. Dobrze, proszę Państwa, ja znowu niestety nie udało mi się tak zalogować do aplikacji, żebym przeczytał pytania z aplikacji, także bardzo przepraszam. Będę chciał od Państwa usłyszeć pytania w formie ustnej. Pan doktor Kalisz.
I have to say it's an amazing presentation, Dr. James. I'm impressed. Really, really thank you. And I have several questions. The first question is: do you see any difference in the course of the clinical science in the idiopathic syndrome in cats and dogs? Do you have any difference between these two species?
Thank you. I think if it's truly the idiopathic syndrome, I think I would probably still expect an overall improving clinical status in both species. I do think that cats are generally less confident in your diagnosis because, on the whole, it's less common, and also they can present at a variety of ages, as we said. So there's always perhaps a little bit more doubt that you've ruled everything out truly. And so, if I had a cat, for example, that wasn't improving and was sort of waxing and waning, I would perhaps start to question really the diagnosis. You know, as I said, most cases will do well. Occasionally, if they're very severely affected, they might, you know, sort of not recover from those deficits, but most, I would say, would improve.
Yeah. This is my experiences as well, because I see in dogs very fast resolving of the clinical signs, and in the cats it's could last a bit longer, and afterwards stays with the head tilt permanently from time to time. And the second question is, what do you think about the drug in people could be used in the Meniere disease? It's we call it beta-serc or beta-histine. Do you have any experiences with this drug in idiopathic peripheral syndrome?
What was the name of that?
Beta-histine. Beta-histine. Beta-histidine.
I don't have any personal experience with it, if I'm completely honest. So I wouldn't be able to comment too much on that.
Okay. And do you have any experiences with cholesteatoma?
Yes.
Yeah. In dogs, do you prefer the lateral bulla osteotomy or ventral bulla osteotomy?
Yeah, I mean, to be honest, I generally have that discussion and sort of led by the surgeons, the soft tissue surgeons. I think probably most often, I would say they tend to do the ventral approach, but yeah, I think it mainly depends on, you know, where the bulk of the lesion is, I think. But yeah, it's not myself doing those surgeries, so I haven't done it myself.
Thank you very much. Any other questions, proszę Państwa? Jest jeszcze czas na jedno pytanko. Może ktoś ma ochotę? So I would have a question, but short one. How can we distinguish, Dr. Kalisz already mentioned it, we have a permanent head tilt after, let's say, healing of the peripheral vestibular system syndrome. So there is a permanent head tilt. How can we distinguish between already a patient that is already healed from the patient that is not yet ready? I mean, that could be still improving, or it might be a chronic case.
Yeah, it can be difficult. I think I guess in my experience of these cases, probably the head tilt is the thing that's most likely to be permanent. I think particularly after severe otitis media interna. I mean, often the owners will say that the coordination of these dogs and cats is sort of very gradually improving, and they're noticing subtle differences, day to day, week to week. And I think, sometimes if we do our neuro exam, we might find that in a central case, the postural reactions are slowly improving. We get those kind of subtle changes. I think the important thing is if it's an idiopathic syndrome, generally once we start getting that improvement, there shouldn't really be a reason why it gets worse again. So, if that happened, we would start to question, has it had a second episode of that, or does it actually have a different diagnosis at that point?
That's absolutely correct. For me, I have the same experience. I would have also impression that sometimes what could be helping is the presence or absence of the nystagmus, right?
Yes.
Because if it's improving or not improving, and the head tilt can be still permanent, right?
Yeah,
Okay. Is there a question? No, that's something different. Good. So. Thank you very much, and I think we could continue to the second, I think, amazing topic, myelopathies that could be operative or non-operative, więc zaburzenia rdzeniowe, kręgosłupowe, operacyjne i nieoperacyjne.
Thank you. So the next talk is on something completely different, really. So looking at myelopathies, so diseases of the spinal cord in dogs and cats, and ones that are surgical or non-surgical, and sort of a broad overview of the things that we commonly see. So I'll just go over again some anatomy, which I like to do at the beginning. I'll mention a bit about grading spinal cord injury, which from an evaluation point of view is probably the most important thing to do. Look at some different intervertebral disc herniations, and then finally some other myelopathies. And it's certainly not an exhaustive list, but I've tried to include maybe ones that we are seeing more often than others. So just to recap again some anatomy, the spinal cord coming off the back of the brainstem is divided into segments, and from each segment we have a pair of nerve roots that comes off. So in both dogs and cats, thankfully they have the same number, so we have 8 cervical segments, 13 thoracic segments, 7 lumbar segments, 3 sacral segments, and then a variable amount of caudal or coccygeal segments. But functionally and clinically, it's more useful to divide it based on this system. So in the cervical cord, we refer to C1 and C5 as a unit. C6 and C2 is where the spinal cord slightly swells and is larger in diameter, because we're going to see in a moment that's one of the intumescences. T3, L3 segments, and the L4 to S3 segments. So that's generally, as neurologists, more what we work on. And so within the spinal cord, we have different types of neurons. So the upper motor neurons originate generally in some region of the brain, and they descend the spinal cord, and they synapse onto the lower motor neurons, which are the cell bodies of which are contained within those intumescences, and that's why they're thicker. So the presence of all those lower motor neurons gives us those slight swelling of the spinal cord in those two areas. So the upper motor neurons, as I say, come from the brain. They descend the spinal cord to our lower motor neurons, which in turn travel into the peripheral system and innervate the muscles. So the upper motor neuron system, its main function is to inhibit the extensor muscles on that side. So they have a predominantly inhibitory effect on the lower motor neuron, although they do facilitate some flexor muscles. And it's mainly responsible for initiation of voluntary movement, maintenance of the muscle tone and anti-gravity support, and regulation of posture. And so if we get a lesion of the upper motor neuron. So for example, a T3 to L3 lesion, what happens is we get generally a decreased inhibition on the lower motor neuron. So they're released from that inhibition, and it means that we get more extension of the muscles in that limb. So we see proprioceptive or spinal ataxia. Obviously, this is everything caudal to the lesion generally. Weakness, paresis or paralysis. We get a normal to increased muscle tone, a normal to increased spinal reflexes. So that's when you do your patellar reflex with your tendon hammer, or your withdrawal reflex, so you pinch the toes and the dog withdraws the leg. Those are generally normal or increased in upper motor neuron lesions. And sometimes you get a muscle atrophy which tends to be quite late and mild. So yeah, more activity almost of the lower motor neuron on the extensor muscles. Whereas the lower motor neurons, as we say, originate from grey matter in the spinal cord at the C6 to T2 and the L4 to S3 portions. They exit the spinal cord and travel via a specific nerve, such as the sciatic nerve, to a group of muscles, in that case to the caudal thigh muscles. Provides innervation to the muscles and allows them to contract. So again, necessary for our posture, gait, and support. So if we get a lesion in those segments, the C6 to T2 or L4 to S3, we tend to get a lower motor neuron lesion where the muscles fail to activate. So again, we do see paresis or paralysis. It has a slightly different quality to the upper motor neuron lesions, but we will also see decreased to absent muscle tone, decreased to absent spinal reflexes, and again, muscle atrophy, which is often, so a neurogenic muscle atrophy, which is often early and severe. And so that leaves us when we try and localize the lesion in these dogs. This is basically what we use. So if we have a lesion in the C1 to C5 portion, obviously that will affect all four limbs generally. It will be an upper motor neuron lesion in all limbs. The C6T2 area, we get lower motor neuron signs in the forelimbs and upper motor neuron signs in the hind limbs. T3L3, obviously we don't tend to expect neurological deficits in the forelimbs, but generally we'll get upper motor neuron problems in the hind limbs. And then the L4S3 segments, we get the lower motor neuron signs in the hind limbs. So that kind of forms the basis of neurolocalization of spinal cord diseases. And that allows us also, we then also attempt to grade the injury. And this is probably the single most important thing you can do in terms of trying to determine the prognosis in these patients. So we'll often use this modified Frankel scale, and there are some variations as to the exact numbers, so that you have to choose which one you want to use, but I've gone with this one. So obviously from a normal patient with a grade of 0, a patient with spinal pain but no actual neurological deficits would be grade 1. If they're still walking but they have weakness and ataxia, grade 2. If they're not able to walk independently with weakness and ataxia, so they're still moving the legs, grade 3. If they're paraplegic, sorry, I should bring this up. So paresis means weakness of voluntary movement. So for example, tetraparesis is weakness in all 4 limbs, whereas plegia refers to a complete absence of voluntary movement. For example, paraplegia, no movement in the pelvic limbs. And the most severe grade there being grade 5, which is paraplegic without the ability to feel the legs, because at the same time as those motor neurons, we obviously also have sensory neurons that are traveling the other direction. And so if we have a complete spinal cord injury, we won't get any information passing through. So I'm sure you've all seen this kind of thing before. So this is a dachshund presenting with acute onset of inability to walk. We can see that there is no voluntary movement of the legs. So, forelimbs are normal, so it means probably we have a lesion caudal to that. The withdrawal reflexes seem to be normal, so if we pinch the toes, the limbs do withdraw, But important to remember that's not a test of feeling or sensation. That's just a local reflex. The way we test deep pain or nociception is we generally would use a pair of forceps and we'd pinch over each side of the digits. And you can see there's very clearly no conscious reaction from that dog to that stimulus. So no deep pain sensation. Whereas and this was very gentle, but he obviously, that's the kind of reaction we would be expecting if the nociception was present. And so for this dog, we can say he's paraplegic without nociception, which means we have a grade 5 spinal cord injury. The withdrawal reflexes, as we said, are normal, so that tells us we have probably a T3 to L3 lesion in the spinal cord. And no guesses as to what that might have been, so look at different conditions of the intervertebral disc, which is probably the most, well, by far the most common thing we see generally. Sorry, back to a quick bit of anatomy again, but we've looked at the spinal cord. Obviously, that sits within the vertebral canal. And between each vertebra, we have an intervertebral disc, which is sort of like a bean shape. So the blue outer part there is the annulus fibrosus, and then the inner part, the nucleus pulposus. And yeah, we have those pair of nerve roots coming off each segment on our spinal cord. And that's how we see it on MRI. So the normal intervertebral disc should have a very nice bright appearance on a T2 image MRI, because it basically, the nucleus is full of water in the healthy disc. And then on the transverse section there as well. And so we can have what is the number one cause of myelopathy in dogs. We can have an intervertebral disc extrusion. So this is the classic Hansen type 1, originally described by Hansen, I think, in the 60s, I think, where we get replacement of the cells in the nucleus pulposus by chondrocytes in a process we call chondroid metaplasia. And that tends to happen in chondrodystrophic dogs. So those are obviously Dachshunds and French Bulldogs making up the majority of what we see in our hospital, but others on there as well. And we can get this in any breed of dog, even if they're non-chondrodystrophic, but much less common. And the peak age of onset is between around 3 and 6 years old, so usually middle-aged dogs. And so you can see there, that's what happens. So we get a rupture in the top of the annulus fibrosus, and we get some of that nuclear material herniating through the top and compressing the spinal cord and the nerve roots. And the nature of the injury is usually a combination of contusion or concussion and compression. So if these dogs are presenting very acutely, often there's been some force behind that extrusion, and there's some bruising and contusion to the spinal cord. And then that material can sit there and start to push against and compress the spinal cord. And this is an example on the MRI scan. So you can see there that I think this was a T13L1, I think. The spinal cord is severely compressed by this very dark, hypo-intense material herniating from the disc space. And so there's two main ways we can try and treat these dogs. One is through conservative or medical management. We generally give an anti-inflammatory, such as non-steroidals, and sometimes other analgesia if necessary. Most commonly, probably paracetamol, gabapentin would be the ones we typically go for. And possibly more important than that, the exercise restriction, the rest in these dogs. So generally, we recommend confining them to a crate or a pen area for 3 to 4 weeks, avoiding running, jumping, stairs as much as possible. And the main reason for that within the first probably month after the injury is that while there's a weakened annulus, there's still a rupture there. We can get more material herniating through there, adding to the compression, and that's often why these dogs would get worse. So often I think the issue is that perhaps sometimes they're given pain relief medication, the dog feels much better, the owners don't rest it, it goes and jumps off the sofa, and it herniates more material and they come in worse. If we do that, it doesn't eliminate the risk that they can get worse, but it tries to minimize it as much as possible. So I think patients to consider that treatment in are generally ones with no to mild neurological deficits, so generally the ones with a grade of 2 or less, so those that are ambulatory, the ones that are improving, or the ones with financial limitations that can't afford necessarily MRI or surgery. And then there's also the surgical approach, so where we try to remove the compressive element of the injury. So the way we do that depends on the location, but most commonly we're doing a hemilaminectomy, which is something that like that, to go in there and make drill a window of bone over the site of the disc extrusion and remove that as much as possible. Sometimes we do a dorsal approach, and probably in the cervical spine, we'll most commonly do a ventral slot to approach from underneath. And so, as a general rule, the patients which we tend to take to surgery are ones that can't walk independently, so they're grade 3 or above. If they're getting worse, despite our conservative management, we tend to step in there and try to prevent that continual progression. Or if we have patients with pain that we can't manage or recurs every time we stop medication, even if they don't necessarily have neurological deficits, it might be that surgery offers the best chance of those dogs being free from pain. And so this is a nice thing a nice sort of review in Frontiers about prognostic factors, which I think is definitely worth a look if you're seeing these dogs in practice. So this is the prognosis for disc extrusions in the thoracolumbar spinal cord based on the grade of injury and the choice of treatment. So important things there are that you can see basically dogs that can move the legs have a relatively good prognosis with conservative management. So 70 to 80% reported to improve and recover. But those same dogs, and also the ones that don't have the movement in the limbs but have the deep pain present, have upwards of 90% recovery rates with surgery. You can see that jumps down quite significantly to about 60% in dogs that are paraplegic without deep pain. So the presence of deep pain is probably the single most important thing to advise these owners on prognosis. And the other thing to be aware of is the percentage of dogs that develop this condition called myelomalacia, which is reported to be generally between 10 to 15% in deep pain negative dogs, and possibly up to a third of French bulldogs. So I would often be more cautious about my prognosis in French bulldogs, particularly those that don't have deep pain and have progressed very quickly. I'm often a bit worried by that. And myelomalacia is a quite nasty condition that is a progressive necrosis of the spinal cord, starting at the site of the injury, but progressing both cranially and caudally. The most important risk factor is how severe the grade or the injury is. And it's thought to occur, as we said, probably around 10 to 15% of dogs without deep pain, but higher in French bulldogs possibly. Usually it would develop within a few days post-injury, but maybe as late as around 14 days. So unfortunately, it's always something I discuss with dogs that come in with a grade 5 injury with the owners, because there's a possibility there that we do surgery, everything goes well, and then within the days afterwards, we get a progressive myelomalacia, and unfortunately, there's no treatment for that condition, and those dogs are euthanized. So clinical signs we look out for in those cases, generally in a grade 5 patient, or if we get cranial advancement of the cutaneous trunci reflex, which basically is where we pinch the skin over the back and we get a skin twitch. If the cutoff gets higher and higher, we would be worried by that. If the dogs are increasingly painful and we don't really have an explanation for that, if we get a sudden or quick loss of muscle tone and reflexes in the hind limbs, which were previously had normal muscle tone, and then eventually, even if the initial lesion was in the thoracolumbar region, we get if that condition progresses cranially, we get involvement of the forelimbs. And if we get weakness of the forelimbs, and eventually, as it starts to progress up the cervical cord, problems with respiratory effort and drive. So generally by that stage, euthanasia would be recommended. And this is how we sometimes see it on MRI. So there are some things we look for on MRI to kind of increase or decrease our suspicion of that. And these aren't definitive, but we would be a bit more concerned if we had an increasingly long T2 hyperintense lesion within the spinal cord. So that spinal cord is very patchy, bright, looks quite swollen because we're losing some of the CSF signal either side. And sometimes you get areas of hypointensity in the spinal cord. So not a nice condition. So the other form of, or the other main form of disc herniation is intervertebral disc protrusion, which is the Hansen type 2. This is due to fibroid metaplasia, so different from your chondrodystrophic breeds. Tends to affect larger breeds of dogs, such as the Labrador, German Shepherd, Border Collie, and usually a bit older, more than sort of 5 years old. And as opposed to the disc extrusion we saw before, this is kind of how it looks. So the nucleus is still contained within the annulus, but the annulus becomes weak on top and starts to protrude upwards and put compression on the spinal cord. And so we don't tend to see a concussive injury. This is more of a compressive injury and usually occurs more gradually rather than acutely. On this MRI, this was a disc protrusion at L7S1, which is quite a common location. Obviously, that last, the last lumbar intervertebral disc. So kind of nice, smooth, looks quite similar in a lot of ways, but a nice, smooth bulging of the disc upwards into the vertebral canal. And again, a couple of ways we can approach that. So in a similar way, we can try conservative therapy. Usually for chronic disc protrusions, I would tend to go for anti-inflammatory prednisolone, starting at maybe 0.5 mg per kg once to twice a day, and then gradually tapering that over perhaps 6 to 8 weeks. And sometimes we can use that almost as like a pulse therapy, so to give relief to those dogs as and when they need it, or perhaps they need to be on something long term, but we can find the lowest effective dose. Again, analgesia if required, and sometimes if it's appropriate, physiotherapy and hydrotherapy, for which we generally prefer underwater treadmill to free swimming for most spinal conditions, I would say. We can also do surgery, so again, to try and decompress the spinal cord. Techniques are very similar, but sometimes we'll, for example, in this case, we've done a hemilaminectomy again, but we've combined that with a corpectomy, and that's to remove part of the vertebral body adjacent to the disc, and that basically should allow us to pull down the annulus material and try to decompress the spinal cord, because these are often more chronic and difficult to decompress. And so generally the rate of deterioration post-surgery is higher in these cases, maybe reported around 30%, which usually is temporary, but occasionally can be permanent if there's more significant damage. And that's likely due to the length of time the spinal cord has been compressed. Maybe we get some reperfusion injury where once we have decompressed, and generally the spinal cord is less able to cope with the effects of the surgery. And sometimes in these dogs, they'll have more than one disc protrusion. They may have multiple, and we might be a bit reluctant to go to surgery based on the fact that we may not know which one is actually causing the problem, or if it's just a combination of all of them. So those are the two main types of disc herniation we see. There are some other types that we do also see quite commonly. So for example, we have a hydrated nucleus pulposus extrusion. This was previously called discal cyst, although it's not in fact a cyst. This is where we get, again, an acute herniation of nucleus material, but crucially this is well hydrated, healthy nucleus material. And so it has a slightly different appearance on MRI, and generally means that you're less likely to see it on perhaps CT or radiographs because the material isn't mineralized. And again, we get sometimes a acute contusion and compression of the spinal cord, and these seem to be more common in the cervical spinal cord. So this is a case of that, so a hydrated extrusion. You can see that we still get that material coming from the disc space. It sort of blends into the CSF signal because it's basically still full of water, but we still get that compressive effect on the spinal cord, and they report a seagull sign on MRI, so the transverse images, which if you squint really hard, you might be able to see a bilobed appearance to the material on the MRI. And in terms of the way we treat those, this is a couple of studies looking specifically at that condition. So the first one, 34 dogs, 18 had conservative treatment, although 2 later had surgery due to poor response to treatment. But overall, all of the cases had long-term follow-up. All of the cases with long-term follow-up were neurologically normal in the long term, regardless of whether they had surgery or conservative treatment. And then this second study, which had a similar number of dogs, again, 18 conservative, 18 surgical, and the sort of median time to regain the ability to walk was within a week for both groups. And so overall, with the hydrated extrusion, at the moment it seems that both conservative and surgical treatments have similarly favorable outcomes. So more often, we're probably not operating on these dogs, at least in our hospital. The next one, this is a lot of acronyms, a lot of letters. We had HNPE, we've now got ANNPE, which is again similar. We get an acute herniation of the nucleus again, but this time it's a very small volume that extrudes very forcefully. So hopefully this works. You can see the disc there. We've had a very small volume of nuclear material pop out, and that basically hits the spinal cord with force, leaves behind a bruise or a swelling. Generally, the history in these dogs is often they're exercising, they're chasing after a ball, they'll suddenly yelp and be off their back legs. That's probably the most common situation. And at least in our hospital, probably Labradors and Border Collies are quite common for this. So sometimes there's pain at the very beginning, but that should quite quickly subside because we don't have ongoing compression. And generally, again, we consider this a non-surgical condition because actually there's nothing for us to remove there. There's no material left behind. So you can see on the MRI here, we have this patchy hyperintense lesion above the disc space almost. And if you compare the volume of the nucleus of the discs, you can see that that particular one shown by the arrow is smaller, so that has lost a portion. And then we have that intraparenchymal lesion right above it. So that's what we refer to as an ANNPE. And then another one within this group, and probably this is a bit more perhaps controversial to include in the disc herniations because we don't know for certain that this is coming from the disc, but fibrocartilaginous myelopathy, or FCE, where we get a small piece of cartilage material that blocks one of the blood vessels to the spinal cord, which is kind of in this sort of pattern. So the reason, so it tends to affect like one of the branches of the ventral spinal artery that supplies mostly the gray matter in the spinal cord. Basically, that means that usually it affects one side of the spinal cord more than the other. So the signs are often lateralized, worse in one leg or one side. Again, generally very acute onset, may be painful at the very beginning, often as well can occur during exercise. The important thing there again is that after maybe 24 hours, we don't expect the clinical signs to progress any further usually. And the prognosis tends to be good in most cases. Again, it's a non-surgical condition generally because we don't have material to remove there. So we don't know exactly where that material comes from, but there is a thought that perhaps it comes from part of the disc and is forced into the vasculature somehow. maybe changes in abdominal pressure during exercise kind of force that material out. So this is very similar to the last condition, the ANNP, where we have this kind of poorly defined lesion in the spinal cord. Often it's a bit longer, it's kind of less focal, maybe not centered above one of the disc spaces. And again, you can kind of see it's mostly lateralized to the left side of the spinal cord in this case. And then the final one in that group is also a type of disc extrusion, more of a traumatic extrusion, which can happen because of an external trauma, like a road traffic accident, for example, which we get a sudden rupture of the disc, generally unrelated to the health of the disc, because that obviously is a result of direct trauma. So actually, although we have the two classic types, there are some others that we now see quite commonly, and as I say, the FC, some theories as to whether that's a form of disc herniation or not really. And this is just how I've grouped them. This isn't really an official thing we do, but so that's mostly things, disc problems. We do see some other myelopathies, and as I say, I mean, there's a whole host of things that can cause spinal cord disease, but I've tried to focus on a few specific conditions that we see. This is one that's currently a lot of research going into this condition at the moment, something called a spinal subarachnoid diverticulum, which again was previously referred to as a cyst, but wrongly. It's a fluid dilation of the subarachnoid space. So you can see there that either around the spinal cord we have the CSF flowing, and if we get like an outpouching of that fluid that starts to compress the spinal cord, we can get problems in the limbs. So it tends to cause a slowly progressive ataxia and paresis. And with this, incontinence, particularly fecal incontinence, seems to be quite common. Generally, we see it in pugs, French bulldogs, Rottweilers, usually male dogs with an age of onset of perhaps a few years old. It's unclear if this is a congenital or acquired condition. A high proportion of dogs seem to have more than one pathology around that site of the diverticulum, so we don't know if there's some instability at that location. Certainly in pugs, there seems to be maybe an association with dysplasia of the articular processes, which are the joints between the vertebrae. So maybe we have sort of, chronic instability contributing to the formation of that fluid. These can be a bit trickier to spot on MRI sometimes, but you can sort of see this like teardrop appearance to the CSF as it forms this kind of pouch, often dorsal to the spinal cord. And again, the treatment is a lot of kind of work into this at the moment. Sometimes we will treat conservatively, again with sort of low doses of steroids tapered over weeks to months. Generally, there's a overall consensus that surgery maybe offers a better recovery in these dogs. So there are various techniques depending on the hospital, depending on the neurologist. Generally, we'll do a hemilaminectomy, dorsal laminectomy. We might combine that with a durotomy, so to cut into the dura. Sometimes place a shunt to actually try and minimize the recurrence of the cyst, not the cyst, diverticulum. Or sometimes some people will prefer to stabilize with implants and may not even do a hemilaminectomy. But there's, again, it's a bit unclear at the moment as to what might be best. On the whole, so in this study, for example, in 37 dogs treated medically, around 30% improved, 40% deteriorated. And in the surgically treated dogs, around 80% versus 16%. So it seems like probably, surgery is going to offer these dogs a better recovery rate, although I think the risk of recurrence further down the line is relatively high, at least in the cases we've seen. Cervical, I think I'm okay for time. Cervical spondylomyelopathy, previously called, has many names, such as wobbler syndrome. Generally, this is when we get compressive lesions in the caudal cervical spine, which can be static, so they're always present, regardless of the position of the neck, or they can be dynamic, so they worsen or improve depending on where the neck is positioned. Usually we have a chronic progressive history of abnormal gait, usually in all four limbs, and may have neck pain as well. And classically it's this two-engine gait, which we're going to see in a moment, where we get almost different things happening in the forelimbs and the hind limbs, and often that's consistent with a lesion in the caudal part of the neck, the cervical cord. And there's two distinct types of this disease. So the first is disc-associated CSM, usually middle-aged large breed dogs, opposed to breed being the Doberman, where we get that kind of intervertebral disc protrusion, maybe with some ligament hypertrophy. So you see there the yellow structures where we sometimes see thickened ligaments contributing to that compressive lesion. Most occur at C5, 6, and C6, 7, and around half of dogs have more than one compressive lesion. So this is taken from a nice summary of imaging findings in these dogs, where we have an example of the ligament hypertrophy dorsally and the disc protrusion ventrally. And sometimes we see that small focal change within the spinal cord, which might suggest we have a very chronic lesion. And the second type is osseous associated, so usually young adult giant breed dogs, classically the Great Dane, where we get vertebral malformation and almost osteoarthritic changes around the processes of the vertebra. We usually have a very narrow vertebral canal, so the spinal cord is already dealing with less space. Again, most occur at the caudal cervical spine, and around 80% of these dogs have more than one site of compression. And so again, the same group did again, imaging features of this, and a bit less obvious on the sagittal image, but then we look at the transverse and we can see the spinal cord's being compressed from both sides laterally because of really thickened articular processes between the two vertebrae from both sides. And with CSM, so obviously now, having mentioned those breeds, I now show you a miniature Schnauzer, which is my best example of a two-engine gait. So this was a dog with a disc herniation in the caudal cervical cord, which has a very severe two-engine gait where actually the forelimbs are very short-strided, very choppy, whereas the hind limbs sort of longer strides, some proprioceptive ataxia in the hind limbs, and we almost get that kind of discrepancy between the front and the back end. And if I saw that, I would be thinking, does this dog have a lesion in the caudal part of the cervical cord? We can do different forms of imaging, plain radiography or CT, particularly in the osseous forms. MRI is useful to detect the changes within the spinal cord, which might help us with our prognosis. And sometimes we can do kinematic MRI, where we change the position of the neck. We extend the neck almost while we're doing the MRI to see if the lesions change depending on the position. And the treatment is, again, either conservative, as for probably disc protrusion, or surgical. And there are many, many techniques described for this. For example, the ventral slot. Some involve implants to stabilize that region of the spine. I think the overall message is that surgery more consistently leads to clinical improvement in these dogs, but interestingly, maybe doesn't appear to extend the long-term survival time, but perhaps improves the quality of life of those dogs in the meantime. And then the final condition I've put on here is just a quick note on degenerative myelopathy. So this is obviously a non-surgical myelopathy. It's a degenerative disease, mainly affecting the thoracolumbar spinal cord in medium to large breed dogs, more than 5 years old. The German Shepherd being the most common that we see. We get a gradual loss of proprioception and movement in the pelvic limbs, usually over 6 to 12 months. Generally a kind of gradual progression, but eventually it will in theory extend to affect the forelimbs and eventually the brainstem, although most dogs won't get that far before they're euthanized due to welfare concerns. It's a diagnosis of exclusion, so all of our imaging findings would be normal, or sometimes we find disc herniations and that complicates things a little bit, but that might be incidental in the case of degenerative myelopathy. And you can test for a gene mutation, SOD1, reported in some affected dogs to try and increase your suspicion, although not all dogs with degenerative myelopathy will have that. And unfortunately, no kind of specific treatment has been shown to alter the progression of the disease. Possibly the thing that has the most difference in the cases that I've seen is maybe sort of intense daily physiotherapy, perhaps underwater treadmill therapy, all the sorts of adjunctive things which can perhaps help to prolong the rate of progression, or perhaps it's just a placebo effect where the owners feel that they're doing something in some cases. So that brings us to an end on this one. And yeah, any questions? Let me know.
Thank you very much, Matt, for this very good talk. Proszę Państwa, czy macie Państwo pytania? Tam z tyłu jest pytanie, już biegnę.
Thank you for a great lecture. I have a question about disc extrusion. If we are talking about breeds like chondrodystrophic breeds like French Bulldog, Dachshund, and we decide we had to operate and do hemilaminectomy or the ventral slot, in your opinion, we should do also fenestration during hemilaminectomy? And if you say yes, how many intravertebral spaces is fenestrated?
Yeah, good question. So fenestration is, for those who may not know, is where we, as well as the hemilaminectomy and the decompression, fenestration is where we make a hole in the side of the disc, in the side of the annulus, and we try and scoop out as much of the nuclear material that's left behind. And the thought is that perhaps it decreases the risk of the short-term recurrence. I think different people do it differently. I mean, for me personally, if I can, I'll tend to fenestrate the affected disc, the one that has had the extrusion. I won't generally do the adjacent ones. Sometimes that's easier in the lumbar spine as opposed to the thoracic spine because you have the ribs in the way, which sometimes don't help. And if I can't do it, then I won't do it. But I mean, sort of another neurologist in my clinic, Fabio, he will, for example, fenestrate probably the two adjacent discs if he's in that thoracolumbar region. And I think the overall consensus is that we should be doing it. It probably does decrease the risk of the short-term recurrence. But I would usually maximum do the one affected one. But that's not necessarily the right answer. So obviously the majority of disc extrusions occur probably between T11 and T11, L4 in most dogs. Certainly Dachshunds tend to be that sort of region. So if we already have access to that region, there is an argument to say we should fenestrate the ones adjacent.
Are you satisfied with the answer? Yes. Very good. Thank you. Thank you. There's another question from Dr. Mederski.
I would like to ask you about your approach and your material used in the case of cervical spondylomyopathy. Some guys, the distraction and fusion. Which materials, especially spacer, do you prefer using?
Yeah, so I think most commonly I've done the approach where we do a ventral slot and we leave behind some polymethyl methacrylate, PMMA, to like a cement to try and reduce the risk of subsidence. So generally we're not, in our hospital we don't tend to place this, we don't place the spacers. We're not so commonly putting implants in. I think in general we're seeing that condition not so often. In our region we don't see many of the predisposed breeds generally, so it's not like we're getting lots of cases. But yeah, there's, as you say, kind of differing consensus on what's the preference.
Thank you. We have still time for one question left.
Okay, I know it's a quite tricky question, but what's your opinion about timing of the surgery and type 1 Hansen disc extrusion? Your opinion is we have to perform the surgery right away, or we can wait for a while to see what's happened in the future? What's your approach?
Yeah, so there's differing sort of evidence on that. So I guess the most common situation we find is that maybe a dog that's gone off its legs within 24 hours perhaps and presents to you unable to walk. As a general rule, we are not operating during the night. So basically, if the dog comes in late in the afternoon or evening, we will tend to operate the following morning. That there is evidence there to suggest that that shouldn't have an impact on the recovery rate. But yeah, the difficult ones are the ones that present with paraplegia and they have the deep pain present, because you know if that's lost, you will be saying we have a 60% chance of recovery, and that's decreased. So those are the ones that are perhaps more worrying. So if you know, if it's at a reasonable hour, we will try and cut those. But yeah, within reason.
Okay, and the contrary situation, when you perform the conservative treatment, so we leave this disc material in the spinal canal. What is your opinion? What happens in the future with this disc material when we perform the conservative treatment?
Yeah, so in the classic disc extrusion, I mean, there are reports of, so there's a lot of work coming out of Cambridge, particularly on the conservative management, that suggests maybe the prognosis is, at least in Dachshunds, is perhaps slightly better than we previously thought, even for those that are deep pain negative, where, as I say, there are reports that a repeat MRI sometimes will show that some of that disc material has been reabsorbed or redistributed, so it can actually, the compression can reduce. Although then in other dogs, you might, if you do MRI, you know, a month, 6 weeks down the line, it might look exactly the same. So I think it varies. The reason why we might get a response to conservative management is that if we have relatively low amount of compression, and yet the inflammation, the swelling, the bruising all improves and recovers, it might be that the dog can live with some disc material in the vertebral canal without causing any issue, and that's what we're hoping for.
Thank you.
Thank you very much for your fantastic lectures, very good questions and best answers. So now we're going to have a break. We're meeting here again 1:15, 15 po pierwszej. Zapraszam na ostatni wykład pana doktora Jamesa dotyczący obrazowania. Dziękuję uprzejmie.
jeden, raz, hej, jeden, jeden, hej, jeden, raz, jeden.
Yeah, no, I'd definitely be interested. I'll just sort of have to run it by my work and see.
people, young people, very motivated. Okej. Dzień dobry, witam Państwa po przerwie. Na ostatnim wykładzie z zakresu neurologii pana doktora Matthew Jamesa. Tym razem będziemy rozmawiali. So Matthew, what are you going to talk about now?
My last talk's about epileptic seizures, specifically the identification of those versus other abnormal episodes.
Fantastic. And then I will have some questions at the end.
Yeah.
Otherwise, if there will be no
Okay.
others. Okay, thank you.
Yeah, thank you for coming. This is my last talk of the day. As I say, it's on something different to the last ones, more on epileptic seizures and specifically identifying those, which seems quite popular. I guess you have a lot of seizuring dogs in Poland. Us too. And cats, of course. We're going to briefly discuss epileptic seizures. We'll also look at paroxysmal dyskinesia, which is increasingly probably the main differential for a lot of those we see. Other episodes that can be confused with seizures. And then finally, summarizing the ways in which we might differentiate those so that we don't end up on the wrong track in terms of diagnosis. So I don't know about you guys, but one of the most common things we see is the owner brings in a dog or a cat saying, you know, he had a fit, he had a seizure. Maybe it was earlier that day, just an abnormal episode. And 9 times out of 10, you examine the animal and it's normal, and so you get no clues. And therefore, you have to get all your clues from the owners, which is, in my experience, more difficult sometimes. But yeah, they can. So the owners often use different terms for what can be a seizure. So, we get owners that describe them as having a fit, a faint, collapse, convulsions, spasms, and even funny turns. So those are just some of the kind of things that owners will come in to us saying that their pet has had. And just to mention some of the terminology that we refer to. So an epileptic seizure is a physical manifestation of excessive and synchronous, usually self-limiting, hopefully, activity of neurons in the brain, specifically in the forebrain. A reactive seizure is an epileptic seizure that occurs as a response from the normal brain to a temporary disturbance in function. So most commonly toxic or metabolic disorders. And with a reactive seizure, it should cease and be reversible when the cause of the disturbance is addressed. Whereas epilepsy is a disease of the brain characterized by recurring epileptic seizures. And clinically, we define that as having at least 2 unprovoked seizures that are more than 24 hours apart. That would be an animal with epilepsy. And so epileptic seizures have different phases, which you might see. So first, we can have a prodrome. This is a set of signs that can occur in hours or days leading up to a seizure. In our patients, the most common prodromal signs can be changes in behavior like restlessness, clinging to the owner, anxiety, other behavioral changes. But sometimes you might not see that, sometimes it's not recognized or it doesn't occur. The ictus is the actual seizure itself. This may be focal, generalized, or a combination of the two, which we're going to discuss in a moment. And the post-ictus is, again, a collection of signs following the seizure that can happen in the hours or days leading up to it, following on from it. And again, that can include behavioral changes, compulsions, aimless wandering, visual disturbances, ataxia, lots of different things, which generally, if they are present, can last anywhere from minutes to sometimes days. So a generalized epileptic seizure is the most probably easy to recognize. So what this means is basically we get involvement of both of the cerebral hemispheres from the beginning of the seizure, and therefore usually both sides of the body. It most commonly in our patients is tonic-clonic, what used to be described as a grand mal seizure. And so tonic refers to extension of the legs, and clonic refers to a paddling movement of the legs. And in general, because we get both cerebral hemispheres affected, in general, the patient will lose consciousness during the ictal phase, and we get commonly autonomic signs such as salivation, urination, and defecation. And this talk has lots of videos you're going to see. Hopefully they all work, otherwise I'm in trouble. So this is a generalized seizure. Fairly easy to recognize. So the dog is unconscious, recumbent. We get abnormal, quite violent movement of all four legs. We get movement of the jaw, salivation. I think this dog also perhaps urinates, although it's hard to tell from a video. So that's a typical generalized epileptic seizure. We can get a focal epileptic seizure, so rather than both hemispheres of the brain being affected, this is where the activity is confined to a small area of the brain, usually within one cerebral hemisphere, and therefore the signs might be predominantly on one side of the body. Depending on the location within the brain, these can manifest as focal motor seizures, where we get muscle movements, so facial twitches, jerking of the head, blinking, twitching, sometimes involving the legs on one side of the body. We can get autonomic seizures where we get parasympathetic and epigastric components. That can be things like dilated pupils, hypersalivation, or gastrointestinal signs. And we can get behavioral seizures, or what sometimes is termed psychomotor seizures, which may, in people at least, they sometimes describe hallucinations, abnormal sensations, which can be a bit difficult to identify in our patients because obviously they can't tell us what they're feeling. And this is an example of a focal seizure. So this is a focal motor seizure where the dog appears conscious, although it is difficult to know if consciousness is normal. The signs are predominantly on one side of the body, with lifting of the left forelimb, twitching of the face, sort of jerking and involuntary movements of the mouth, hypersalivation, anxiety, restlessness. And so that would be what we would consider to be a focal seizure. And the most common type of seizure in our patients, or certainly in dogs, is focal evolving into generalized seizures. So we get the initial focal activity, which then activates the rest of the cerebral hemispheres, and it diffuses throughout the brain, and then we get the generalized seizure. So it starts off as the focal signs and then quickly progresses into the generalized signs, and it might be so quick that we don't recognize that it's difficult to spot. And we might just really see the generalized component. So that would be what would happen. Your patient would start with focal signs. It would then age about 10 years and have the generalized signs, generalized seizure, as we've already seen. And it's just coincidence that these are both border terriers. It wasn't intentional. So yeah, features we look for in epileptic seizures: often abnormal consciousness, which, as I say, sometimes is difficult to evaluate in certainly the focal seizures. Often have autonomic signs present. Often short in duration. Most seizures are less than 4 or 5 minutes, I would say. The recovery, we often have a post-ictal phase where we have abnormal behavior, mentation, abnormal gait. Often those post-ictal changes, the recovery can be prolonged if we have a prolonged post-ictal phase. So moving on to what we probably most commonly see, as a differential for epileptic seizures is this condition called paroxysmal dyskinesia, which probably in the past, a lot of dogs, before we had smartphones, I guess, perhaps were misdiagnosed as having epileptic seizures when maybe it wasn't truly. So paroxysmal dyskinesia is a type of movement disorder, of which there are a group of movement disorders, characterized by episodes, again, of self-limiting, involuntary, abnormal posture and movement. We don't completely understand why it happens, but we believe that there's originates, again, from within the brain, specifically regions of the brain called the basal nuclei. And most are presumed, or in some cases, some breeds confirmed to be hereditary genetic in origin. And these can look different between different individuals and different breeds of patient. But as a general rule, what we tend to see is consciousness is maintained and the animal is aware of what's going on, able to respond to the owners. Usually there's a lack of autonomic signs, although I would say occasionally we do see dogs that salivate a bit as well, so there is a bit of crossover with all this. Normally, once they've recovered, it's quite rapid, and we wouldn't expect to have post-ictal abnormalities once the episode is finished. And again, they have quite a variable duration of seconds, minutes, or sometimes even hours. So if we had an episode that was going on for, more than 10 minutes, hours, and that dog seemed to be conscious and then recovered very quickly, I would be questioning whether that's an epileptic seizure, and I'd perhaps be more considering something like this. So, sorry, I should play the video. So this is a dog where we suspected a paroxysmal dyskinesia. So you can see we've got abnormal kind of contraction of the limbs, lifting of the right forelimb. We have abnormal movements of the head and body, sort of tremoring, but importantly, the dog is aware, seems to affect possibly more than one side of the body, but was able to respond to the owners. If the dog tries to stand, it often has difficulty doing so and difficulty walking, and didn't urinate or defecate. So those are some of the features we're looking out for. And this is, as I say, they can look different, but this is quite a common type of episode we see with this condition. So, and then a key thing again is that once that episode finishes, within seconds to minutes, we have a normal dog again and no lasting post-ictal signs. So with this, movement disorder, specifically paroxysmal dyskinesia, there are again different terms we use. These are more taken from humans, and there's some argument as to whether we should be using this really. But it's just to give an example of what we're looking at. So dystonia is a sustained involuntary contraction of a group of muscles producing abnormal posture. Athetosis is a prolonged slow contraction of specifically the trunk muscles, resulting in bending and writhing. Chorea is an abrupt, unsustained contraction of different muscle groups. And ballism is a contraction of the limb muscles, resulting in flailing movement of the limb, which is often unilateral. So these are just kind of some of the ways in which we can describe some of the movements we see within these movement disorders. And so these currently are the paroxysmal dyskinesias that have a proven genetic mutation behind them. Probably the earliest, I think, was the Cavalier King Charles Spaniel with episodic falling syndrome, with a BCAN mutation, often resulting in this kind of deer stalking or preying posture, hunched, so kyphosis is hunched spine, and then, so perhaps some response to medications such as acetazolamide, clonazepam, and there are others. So we've got the soft-coated Wheaten Terrier, the Shetland Sheepdog, the Marquis dog, which I don't know if I'm saying that right, and the Weimaraner with genetic mutations reported. Breed-specific conditions. And there are many, many more breeds that are affected that we don't know if there's a genetic mutation yet. So this was a group of dogs that we reported on with so this is the Weimaraner, which was relatively recent. These kind of episodic movement disorders, which was a group of young Weimaraners, I think around about 5 months old on average, where we had these episodes which occurred during exercise or excitement, which was a bit more unusual for this, but sort of abnormal gait in the pelvic limbs, bunny hopping, kyphosis, so very hunched in appearance, sometimes leading to collapse. And the crucial thing there that these signs occurred episodically, so they lasted 5 to 15 minutes. And once they were finished, the dog went back to normal and didn't seem to suffer any consequences of that. So yeah, in those particular dogs, we described a mutation in TNR, which is encodes for something called tenascin, which is involved is a constituent of the extracellular matrix, similar to the role of BCAN that we mentioned in the King Charles Spaniels, and is expressed exclusively in the nervous system. There were only 4 dogs in that study, but the 2 that were treated with fluoxetine, and both improved very well. So they went from having almost daily episodes to pretty much none at all. We don't have that long a follow-up on those dogs yet. So this was another case in which similar kind of abnormal gait, which caused the dog to collapse in that way. So most, I would say, of these paroxysmal dyskinesias occur at rest, but occasionally you might see it where they're induced by excitement or anxiety as well. And this is another form of it. So this is what's been described in the Border Terriers, what has been described as canine epileptoid cramping syndrome or Spike's disease. And what was found in these dogs is that, as well as these sort of abnormal episodes, they had at the same time quite frequent gastrointestinal problems such as vomiting, diarrhea, and borborygmi. And some work done through this group, led by Mark Lowry, found that a lot of these dogs have an increased serum antibodies against transglutaminase 2 and gliadin, which basically appears to be part of a gluten intolerance in these dogs. So we consider this in Border Terriers to be a gluten-sensitive paroxysmal dyskinesia, which means that the best form of therapy is often converting to a strict gluten-free diet for at least 3 months to see whether that helps. And there is some evidence to say that this happens in other breeds as well. So sometimes, depending on the history, we might test other breeds or we might trial the diet, but it's a bit less clear, really. It hasn't been as well described. And we also, a few years ago, did a study into Sphinx cats. So this was the first report of paroxysmal dyskinesia in cats. Usually these were young cats, less than 4 years old. And again, episodes of abnormal ambulation, sort of muscle hypertonicity, these kind of strange rhythmic movements of the legs and the back, hunched posture, usually affecting the hips and the pelvic limbs and the forelimbs, also sometimes the head and the neck, the tail, the back. And yeah, we get this kind of often rhythmic movement of the limbs, and these cats seem to be fully aware, fully conscious, and then once the episodes are finished, which generally I think would be less than 5 to 10 minutes, they are back to normal. And the 2 cats in this study, not many, but we followed for a longer time and see the episodes seem to resolve. So it seems like the frequency can fluctuate naturally. And it's also apparent that this can occur in other cats as well. So we're currently doing a study on other breeds of cat with very similar episodes, where we have many breeds within that study, which hopefully will be on the horizon soon as well. So yeah, going back to that table, often we're left with that, trying to distinguish between these two conditions. And the features to look out for are that in comparison to seizures with movement disorders and paroxysmal dyskinesia, we tend to have a normal consciousness. Autonomic signs are often absent, although I have occasionally come across patients that will salivate or pass urine. The duration is much more variable. Recovery is often rapid and without significant postictal changes. So those are all important things to ask, really. And then we see some other seizure-like episodes that might be confused, you know, perhaps by owners or perhaps if the description isn't very thorough. So if you were here yesterday for the inflammatory diseases talk, you may have seen this video already, which is with a dog of a dog with something called a condition called idiopathic generalized tremor syndrome, which is a condition we suspect to be immune-mediated inflammation of the central nervous system, probably of the cerebellum or the cerebellar tracts. And so we get an acute onset of intention tremor. So an intention tremor is one that is worse when the dog attempts to do things, when it attempts to stand, when it attempts to eat or drink. And that's a classic sign of cerebellar disease. And it might also be associated with opsoclonus, which, sorry, I'll replay that. So yeah, opsoclonus is like a rapid involuntary movement of the eyes that is multidirectional, doesn't have a slow or fast phase like a nystagmus, so it's a lot less common. But with this condition, it can occur. So if you watch the eyes, they very much are darting about in every direction. And we have this kind of full body tremor involving the head and all of the legs. And again, the way we kind of try and differentiate this from a seizure is that the dog appears to be conscious. We're not getting kind of extreme violent movement of the limbs. We probably wouldn't expect autonomic signs, and it will also not occur episodically generally. The signs will be persisting because it's due to an underlying inflammatory process. With this condition, usually affects young, small to medium dogs. Previously called white shaker syndrome because they've found it initially in mostly white dogs, but that seems like it can affect any breed or color of dog. And the diagnosis is mainly through a supportive history and signalment and the type of the tremor. We will sometimes do MRI to rule out structural brain disorders. CSF can show mild inflammatory changes. And probably one of the more important differentials to consider if you have a dog presenting with sudden onset tremors like that is perhaps intoxication, for example, mycotoxins. And if there's any doubt as to the diagnosis, we might consider a CRI of intralipid if we're thinking a toxin's a possibility. So we generally treat that condition with immunosuppressive doses of prednisolone, which we taper every 2 to 4 weeks. So that most dogs probably have around 2 months of therapy. We also combine that with oral diazepam every 8 to 12 hours. And most dogs do pretty well. We expect them to improve generally within 48 hours and then continue to improve, although it is possible to have relapses as well as with a lot of our immune-mediated conditions. Another thing to consider that again can be confused with seizures is head bobbing. So we have a specific syndrome called idiopathic, again, head bobbing syndrome or head tremor syndrome, where we get repetitive head tremors in a vertical or horizontal direction generally. And you're going to see this dog is extremely happy, but then has quite a pronounced head tremor. It's quite an extreme case, but it doesn't appear to cause the dog any pain. The dog's fully conscious and responsive to the owner. There's no involvement of the limbs. So this generally would occur in breeds like bulldogs, boxers, Doberman, Labradors. So often they're kind of brachycephalic type dogs, I'd say. Just because it's so good, I'll play it again. Age of onset usually quite young. Most episodes are less than 5 minutes, but can last up to several hours. And really, this isn't a condition we give medication for. So the best technique, if you like, seems to be distracting these dogs, because we think it's maybe a condition related to the stretch mechanism of the muscles in the neck, because if the dogs lie down or they put their head on a surface, the tremor generally stops. And also if you offer them food or offer them toys and distract them, it seems to be that in a lot of cases you can stop the head bobbing early. Fly catching is another one. So it's maybe not the best example of this, but it's sort of when almost as if the dog is seeing things that aren't there. So it looks upwards, looks around the room as if it's following something with its eyes. There's a little bit of jaw snapping in this dog, but often the actual jaw movements will be more pronounced, as if they're trying to catch something. Characterized by episodes of biting the air, sometimes jumping, licking, and swallowing. I think this is relatively poorly understood. It can be linked to several things. And so these dogs can end up having quite an extensive workup. So it can be potentially a manifestation of seizure activity, such as a focal seizure. But also there are some cases in which we perhaps suspect there might be ocular problems, maybe even like floating opacities in the visual field that the dog is trying to chase. It can be linked to gastrointestinal diseases as well. So sometimes they'll have an internal medicine workup, or perhaps even a behavioral disorder, which is like an obsessive compulsion. So it's not very clear sometimes in these dogs what's causing this. I mean, often we'll give like a trial of anti-seizure medications to see whether we can change the frequency of the episodes and try and further rule out a form of epilepsy. So yeah, it can be linked to, it seems, maybe gastroesophageal reflux, in which case there might be a link there to timing in regards to when the dog eats, and sometimes involve neck extension and swallowing, which might increase our suspicion of reflux. And in general, we often find that anti-seizure drugs have a relatively poor response, which makes sense because a lot of them aren't on forms of seizure activity. There are reports of trialing fluoxetine as well. Another one is a slightly obscure one, is something called neuromyotonia. This is a disorder of the peripheral nerves where they are hyperexcitable, and we get a persistent muscle stiffness. The muscles fail to relax effectively, and something called myokemia. So, see if I can play this one first. Myokemia is a term used to describe almost like rippling of the skin, so this like worm-like movements under the skin. So that's myokemia, and that's part of one of the signs we can see in dogs with neuromyotonia. And this is an episode of neuromyotonia where you can see how that might be sort of confused with a seizure, but generally the limbs are very rigid and hyperextended. The dog's actually conscious and sort of aware, it seems. This can be quite a severe condition. So it's been described as a hereditary condition alongside types of cerebellar ataxia in young Jack Russell, Parson Russell, and Patterdale Terriers. And it seems to be linked to a potassium channelopathy associated with this mutation here, KCNJ10. And one of the big problems with this is the hypothermia can be severe due to the muscle contraction and life-threatening, and it is actually something that can persist despite general anesthesia. So if you were to anesthetize these dogs and they were still ongoing, that would start to raise questions as to, you know, is this a seizure or could it actually be something more rare like this condition? And I've personally not seen any cases of this, but generally prognosis is very, very guarded. And then sometimes we'll come across sleep disorders. Sleep behavior disorders, which are classified as a parasomnia, which means it's an abnormal behavior that occurs during sleep. Importantly, it should be able to be stopped if you wake the animal up, and can be quite violent movements during sleep. So this dog's actually asleep in the rapid eye movement phase of sleep, when actually under normal circumstances we should have loss of muscle tone in the body, whereas in the REM sleep behavior disorder there's loss of inhibition of the lower motor neurons, and we get sometimes these violent movement of the limbs and the trunk. And you see when the dog wakes up, well, maybe he's not quite awake, but it should be something that it doesn't occur during a wakeful state. And unsurprisingly, treatment with anti-seizure drugs is ineffective. There are reports of this developing in dogs and in cats, secondary to lesions of the cervical spinal cord, but relatively rare. And so, we've been through a lot of this already, but the ways in which we kind of differentiate all these things, I think key questions to ask for me are, when do the episodes occur in relation to the time of day? Any kind of things happening around the time of those episodes, eating, drinking, exercise. What's the frequency of the episodes? Because obviously if we are looking at epileptic seizures, we need to know how frequent those are, how concerned we need to be. What's the duration? Because as we said, the longer the episode, probably it's becoming less likely we're having an epileptic seizure unless we have quite a severe one or we're in status epilepticus. Does the animal remain conscious and aware? And this is quite a subjective thing, as we've said. Some owners are very good at picking that up, some aren't so much. Which body parts are affected? Because as a general rule, I would say if both sides of the body, if all four legs are affected and the animal is conscious, that to me is less likely to be a seizure, because as we've said, in a generalized seizure affecting the whole body, we would expect generally the animal to be unconscious. Are autonomic signs present? How long is the recovery period? And during that period, are there any abnormal signs? So is the animal normal in between the episodes? And I think the big thing, can they provide videos? So like if there's anything you take home, basically, if wherever possible, ask the owners to take videos, because obviously that can be extremely helpful for us. Another way is through treatment trials. So if we're sort of uncertain, even after the video, we might consider a trial of anti-seizure medication. For example, phenobarbital or levetiracetam would be the most common ones we use. Maybe over a 4 to 6 week period to see if we get a response. Obviously, it depends. How useful that is depends on what the initial frequency was, because if the dog's having daily episodes and you give medication and then they suddenly dramatically reduce, that would be quite convincing for some epileptic activity. Whereas if the dog has one episode every 2 or 3 months, you're not really going to be able to prove a sort of effect of medication there. So sometimes it's not appropriate to do this kind of trial. Obviously, if there's little to no response, so if it was having daily episodes and that continued despite what should be, at least partially effective anti-seizure medications, then that would start to raise questions that this is something different. And then another way is through electroencephalography, or EEG. So this is at our clinic here. We're not often doing EEG, but we'll occasionally get it out and have a go. So this is where we put a set of electrodes over the scalp, and we measure the electrical activity in the brain, and the recordings. So this was a normal dog, so I think this is a normal recording. I'm not an expert in reading EEG, unfortunately, but really that's kind of the only definitive way to tell if there's epileptic seizure activity going on in the brain. Unfortunately, it's something we don't often get the chance to do, but increasingly there are some companies there that are starting to use video EEG, where we have these sort of hats we can put on our patients, and potentially at some point even sort of have them go home for 24 hours, similar to like a Holter monitor even. I mean, maybe some way to go before that, but there have been some studies that, like this company here, for example, has published that show that this is feasible in some dogs and cats that are unsedated. So obviously that's one of the major kind of barriers to EEG for us, is that if you have to sedate, have to anesthetize that animal, it changes the results you're going to get. So maybe that's something we'll be doing more commonly in the future. So yeah, that brings us to the end. I hope that was okay. And thank you for having me over the weekend. I'm happy to take any questions.
Thank you, Matthew, again for a very good, very practical talk. That was one of my questions. What about the EEG? Because I'm very interested in the subject. Proszę Państwa, czy są jakieś pytania do tego naprawdę ciekawego tematu? A propos terapii, leczenia. Nie ma. So Matthew, I would have a question.
Okay.
What do you think about the surgery in epileptic cases?
Yeah, I mean, we had the European conference in neurology sort of a couple of months ago, and actually there was a lot on surgery for epilepsy in human patients, and it's really interesting because there's more and more of that being performed earlier in the course of the disease, where maybe they're sort of even disconnecting the whole cerebral hemisphere so that we don't get spread of seizure activity within the brain, and cutting off those sort of foci of seizures. I mean, it's not something we're doing currently, but I think there's perhaps some very interesting, exciting stuff there in the future as to whether we can look at that. I mean, obviously, with epileptic seizures, there are a whole range of causes. So, like, there's the idiopathic cases, but then if you have specific lesions, for example, a tumor causing epileptic seizures, then obviously we might remove that through a craniotomy to try and improve our seizure control.
Yeah, thank you. And any other options, alternative treatment for epilepsy?
Yeah, I mean, you've obviously got a number of different medications, and then beyond that, if we have patients which are poorly controlled, we'll sometimes look at dietary factors. So there is a neurogenic diet which may help in certain cases. There is some evidence behind vagal nerve stimulation, which has been done in Bristol, and also transcranial magnetic stimulation. So there's a few different therapies out there, I think, all being sort of researched quite heavily at the moment.
Yes. I think there is lots of possibilities, lots of alternatives. I can't wait. Next year I'm going to introduce transcranial magnetic resonance stimulation in our clinic, so I hope it will work. And as to vagal nerve stimulation, there was, like you mentioned, in Bristol, there was a very new startup from Texas presented with a new implant that is put into the vagal nerve, especially for dogs, only for dogs. That was engineered by the battery from a collar, right? Okay, so we have questions. Very good.
Ja zadam po polsku, dobra?
Dobrze, dobrze. Ale to i tak do mikrofonu.
Dobra. Czy jest taka możliwość, żeby levetiracetam był skuteczny w przypadku tej dyskinezy? Tak, bo mam pacjenta, u którego było zachowanie, była zawsze zachowana świadomość podczas tych napadów. Zostało na próbę wprowadzone leczenie lewetiracetamem i jest lepiej. A czy tak może być?
Okay, if you have an experience in using levetiracetam for paroxysmal dyskinesia, because the colleague had a case that was having fits without loss of consciousness, and it was supposed to be paroxysmal dyskinesia, and it worked. So, what do you think about it?
Yeah, I mean, it's interesting. Obviously, we'll occasionally trial medications for paroxysmal dyskinesia. If I was to choose something, it would generally be more along the lines of a fluoxetine or acetazolamide. As a general rule, I don't tend to treat them unless they're very, very frequent or causing the owner lots of concern, because I find that generally it's unrewarding. I would say that if the dog responded very convincingly to levetiracetam, I would start to maybe question a little bit, is that truly a paroxysmal dyskinesia? One thing we see is myoclonus. So myoclonus is like a shock-like movement, which can be a form of epilepsy, which often does respond very well to levetiracetam. So maybe I'd be thinking, could it be something like that?
What do you think about using cannabinoids in treatment of epilepsy?
Yeah, so CBD oil is another one of those options for poorly controlled dogs. I tend to find it's more often the owners that come in and they're already trying it themselves than something I generally recommend. But I think studies so far are a bit split on the benefit of it. There's an argument for and against it. So at the moment, I'm saying to owners that we don't quite know yet. If they want to trial it themselves, then fine. I think I tend to reserve it for those really kind of severely affected cases where we're already on perhaps 2, 3 anti-seizure medications already, and the owners are kind of coming to the point where they need other options. I think it would be very reasonable to trial something like a CBD oil.
Thank you. Thank you very much. Thank you, Matthew, for fantastic talk. And I have a gift from organizers of this conference. It's a history of veterinary medicine.
Thanks. Thank you.
Thank you. You are. It's in Polish, but still it's very good Polish.
Translation.
You're right.
Raz, jeden, hej, hej, jeden, 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 hej, raz, jeden.
Proszę Państwa, nie wiem, czy Państwo są świadomi, że tutaj nie będzie Rafała Niziołka, tylko będziemy my. Dobra.
Czekaj, trzeba powiedzieć, że nie ma dźwięku.
Gdzie się przybierzecie?
No jest to, no,
Nie będzie tego przebrania?
zaraz już zobaczę, gdzie.
Ja się zmieszam. Nie, bo chciałem się pożegnać z tymi moimi...
Przepraszam.
Nie,
Będziesz ludzi czekają.
Mam was... Gdzie pracujecie i tak dalej, czy nie?
Jeszcze raz?
Mam wam przedstawiać, gdzie pracujecie, czy w tych...
No tak, tak, pokrótce tak. To jest, no co będzie na tym?
Ja nie wiem, wyczytał. Białobrzeska, tak?
Białobrzeska
A, to jest
i
nowe.
UMK Toruń.
Jak? A,
UMK Toruń, tak.
A ty Wojtek
Działa czy
nowe,
nie działa?
tak?
Przychodnia nowe. Dobra, to
Jest
co, zakładamy,
dźwięk, czy nie?
nie ma dźwięku.
No to nie, to dajmy spokój.
No szkoda, no dobra, no trudno.
To jest audio nie?
Tak.
Dzień dobry Państwu. Witam miłośników boksu i innych sztuk walki. Przed nami, proszę Państwa, jak już co roku, sparring, może nie do końca bokserski, ale sparring onkologiczny. Przed nami dwóch graczy, dwóch walczących o zwycięstwo wykładowców. Wojciech Hildebrand. Powitajmy go brawami. Przychodnia we Wrocławiu, Neowet. Przychodnia, która się specjalizuje przede wszystkim w onkologii. Tu się przestanąłem chyba. A przed Wojtkiem, przed Państwem i przed walką versus dr Dariusz Jagielski. Przychodnia Białobrzeska oraz Uniwersytet w Toruniu kształcących młode pokolenie lekarzy weterynarii. Myślę, że proszę Państwa, nie ma więcej panów przedstawiać. Fantastyczni fachowcy, specjaliści. Niejednokrotnie ja też konsultuję z nimi swoje przypadki. W związku z czym zabawimy się teraz, proszę Państwa, jak przed rokiem Hildebrand! I Jagielski! Tutaj kolega będzie robił zakłady, bierze pieniądze, w związku z czym na koniec rozstrzygniemy, kto wygrał. Zapraszam.
Bardzo dziękujemy za wprowadzenie, za przedstawienie. Tło, które Państwo słyszycie, nie jest bez powodu. No nie udało mi się kolegi przekonać, bo mieliśmy odpowiednią jeszcze przebranie, ale może następnym razem, niestety. Może go zachęcę na koniec.
Jeżeli ktoś będzie chciał, może sobie zrobić z nami zdjęcie, jak z misiami na Krupówkach.
Dobrze, proszę Państwa, zacznijmy od początku, czyli od tego, że nowotwory gruczołu sutkowego u psów, zarówno i u kotek, są bardzo dużym problemem onkologicznym. Jeżeli chodzi o suki, to jest drugi pod względem częstotliwości występowania nowotwór listwy mlecznej, w ogóle nowotworów. Natomiast u kotek jest to trzeci pod względem częstotliwości występowania nowotwór. U suk najczęściej powyżej 10 roku życia. Jeżeli chodzi o kotki, statystycznie 25 przypadków na 100 tysięcy kotów. No, myślę, że jakbyśmy tutaj zapytali, czy ktoś się nie spotkał z nowotworem listwy mlecznej u suki lub u kotki, to nikt by nie podniósł ręki, bo wszyscy się z tym spotkali.
A żeby zacząć od początku, to musimy naprawdę od początku zacząć. Proszę Państwa, ten temat podjęliśmy dlatego, że pojawiło się trochę badań dotyczących tego, że sterylizacja, kastracja zwiększa ryzyko niektórych nowotworów. To wywołało duży ferment wśród właścicieli. Mało tego, czasami zdarzają się w pewnym sensie pretensje, dlatego postanowiliśmy przejrzeć to, co jest do przejrzenia i zastanowić się, jak tak naprawdę to wygląda, czy ta sterylizacja co nam daje, a jakie niebezpieczeństwa za sobą pociąga.
No właśnie, sterylizacja, kastracja. Sterylizacja, jak Państwo wiecie, wywodzi się jeszcze z historycznego, że kotkom podwiązywało się jajowody, w związku z tym pozbawiano ich możliwości rozrodczych, czyli je sterylizowano, natomiast w tej chwili wszyscy kastrują, czyli pozbawiają chirurgicznie gonad. Jest to chyba najczęstszy zabieg chirurgiczny wykonywany w ZLZ-ach. No, głównie chodzi o ograniczenie rozrodu i tą profilaktykę przeciwnowotworową. Czy aby na pewno? To zaraz spróbujemy Państwa przekonać, podając argumenty zarówno za, jak i przeciw. Sterylizację najczęściej wykonuje się w młodym wieku. Wiemy o tym, że im młodszy wiek, tym mniejsze ryzyko wystąpienia zmian nowotworowych. Oczywiście też robi się zabiegi chirurgiczne interwencyjnie w związku z ropomaciczem. I tu właśnie też kolejne pytanie będzie, kwestia sporu, czy profilaktycznie jest sens sterylizować przy usunięciu guzów listwy mlecznej. Jeżeli chodzi o nowotwory...
Chyba się nie będziemy zagłębiali w patologię, patomorfologię, dlatego że to wszystko Państwo, jeżeli Państwo są lekarzami weterynarii, to musieli zdać te egzaminy. Miejmy nadzieję. Niektórzy studenci są na sali, więc może są osoby, które jeszcze nie zdały patomorfologii.
To tylko gwoli przypomnienia, jak duża może być różnorodność tych nowotworów. Jak Państwo widzicie, nie tylko raki, ale też i mięsaki, też i guzy mieszane. Jedną z cech nowotworów złośliwych, które mogą pojawiają się w listwie mlecznej, jest możliwość dawania wznowy albo dawanie przerzutów. Statystycznie rzecz biorąc, u suk nowotwory częściej występują w tylnych pakietach, czyli 3., 4., 5. U kotek znowuż w tych pakietach doczaszkowych, czyli 1., 2. No i dają przerzuty najczęściej do klatki piersiowej. Ulubioną destynacją nowotworów listwy mlecznej są płuca. No w przypadku niezłośliwych oczywiście tych przerzutów nie ma. I to jest ciekawe zestawienie, to też gwoli przypomnienia, bo Państwo wiecie, że jeżeli chodzi o suki, prawdopodobieństwo nowotworu złośliwego jest mniej więcej pół na pół, 50 na 50. 50% to są nowotwory złośliwe, 50% to...
Troszeczkę więcej
No,
złośliwych.
ale mniej więcej.
Okej.
Natomiast w porównaniu do kotek, no to u kotek, no to przede wszystkim nowotwory złośliwe, nawet do 90% to są nowotwory złośliwe. Najczęściej są to raki, ale też zdarzają się i hiperplazje, też przerosty, nienowotworowe, zmiany łagodne. O. I tutaj przykłady nowotworów. To jest ciekawy przykład, to jest jamnik, który trafił do mnie na konsultację, bo pan powiedział, że był u kilku lekarzy, ale najpierw jeden powiedział, że guz jest za mały, żeby go operować, później powiedział, że on jest za blisko pachy, żeby go operować, później powiedział, że on jest za duży go operować, a na koniec powiedział, że pies jest za stary, żeby go operować. No każdy argument jest dobry. No i zmiany u kotek. Tutaj też przykład hodowcy nowotworu. Zawsze ja mówię, to jak ktoś pyta, czy ma patrzeć i oglądać, jeżeli chodzi o guzy listwy mlecznej, ja mówię, że oglądać to sobie może kwiatki na parapecie, jak rosną. Natomiast raczej nie hodujemy nowotworów listwy mlecznej, staramy się je usunąć jak najszybciej.
Tak. Te dwa przypadki guzów kotek są przypadkami ekstremalnymi, kiedy mamy otwarte rany, perforację guza. Proszę pamiętać o tym, że taki obraz kliniczny, parametr kliniczny, perforacja guza jest negatywnym czynnikiem rokowniczym u kotek. W związku z tym to są ekstremalne przypadki, jeżeli chodzi o kotki. Będziemy mówili o kotkach, tam sytuacja jest prostsza aniżeli u suk. Tam nie ma dywagacji, co robić. W związku z tym to będzie dla nas trochę prostsze. O TNM-ie też nie będziemy rozmawiali, dlatego że musielibyśmy poświęcić na to zbyt dużo czasu. Zwracam Państwa uwagę na ważną rzecz, to jest przy parametrze dotyczącym guza, mianowicie proszę zobaczyć, że rak zapalny jest od razu guzem, który zakwalifikowywany jest do najwyższego stopnia agresywności klinicznej. To się przekłada na zaawansowanie kliniczne oczywiście, ale proszę pamiętać o tym, że raki zapalne a priori są kwalifikowane jako guzy, które już dały przerzuty. Wiemy to dlatego, że rak zapalny zawsze daje przerzuty. Najzwyczajniej w świecie. W związku z tym, jeżeli mamy raka zapalnego, on automatycznie kwalifikowany jest do co najmniej N1, a tak naprawdę jest już M1, czyli wiemy na pewno, że są mikroskopowe przerzuty raka zapalnego gruczołu mlekowego. To są suki, mają tam Państwo przykład u góry. Klasyfikacja TNM u kotek, poproszę klik. Klasyfikacja TNM u kotek jest trochę prostsza, natomiast tutaj nie ma adnotacji dotyczącej guza zapalnego. Po pierwsze, dlatego, że guzki zapalne u kotek są znacznie rzadsze. Po drugie, u kotek w ogóle nie patrzymy na to, czy guz jest mały, czy duży. U kotek pozostawienie guza sutka jest błędem w sztuce lekarskiej. Po prostu najzwyczajniej w świecie. W związku z tym każdy guz od razu jest kwalifikowany do zabiegu. Dlatego nie zastanawiamy się, czy guz jest już dostatecznie duży, jak mówił Wojtek, do zabiegu, czy może jest za duży, to czasami się zdarza. Dobra. Klasyfikacja jest prosta, Państwo to znają. Jeżeli na sali są studenci, którzy nie zdali patomorfologii, to trzymamy za nich kciuki. Żyję tą nadzieją, że zdadzą patomorfologię. Tym bardziej, że moja córka jest na weterynarii.
I potencjał złośliwości objawia się też przerzutami. To jest Nokia, która miała guzek wielkości dosłownie łebka zapałki, czy główki zapałki. i ten guz już dał przerzuty, bo wielu osobom wydaje się, że mały guz
Dzień
to
dobry.
nie daje przerzutów, że dopiero duże guzy z czasem dają przerzuty. Moja kotka niesterylizowana miała przerzuty guza, który praktycznie był niewyczuwalny. Był ledwo wyczuwalny, on miał wielkość łebka szpilki, natomiast u tej suki ona przyszła z objawami duszności. Nikt nie wyczuł nic, duszność osłuchiwałem. Jak Państwo wiecie, takie guzy nie zawsze dają objawy wysłuchu, w związku z tym wysłałem na prześwietlenie. Wysłałem na prześwietlenie, stwierdzili, że ma bardzo dużo zmian metastatycznych. Dopiero wtedy w drugą stronę zacząłem szukać, no gdzieś musi być ognisko pierwotne. Męczyłem się z tym psem chyba z pół godziny i wreszcie znalazłem tutaj taki malutki sutek przy 5. prawym gruczole sutkowym, który okazał się być tym źródłem pierwotnym tego guza. Tak więc wielkość guza nie ma interakcji z potencjałem przerzutowości. Jeżeli jest guz złośliwy, to tak mały guz też może dać przerzuty. Albo przerzuty, tak jak u tego owczarka niemieckiego, powiedzmy owczarka niemieckiego, guz już duży, ale przerzuty do ośrodkowego układu nerwowego i zaburzenia neurologiczne. Zaburzenia neurologiczne też mogą być objawami przerzutów, chociażby z gruczołu sutkowego. Mogą być też przerzuty miejscowe w obrębie listwy mlecznej. Tutaj były przerzuty i tutaj naciekanie skóry w związku z silnym potencjałem złośliwości i w tym przypadku też były przerzuty do klatki piersiowej.
To jest, proszę Państwa, algorytm, który ja zrobiłem analizując to, co wiemy na temat guzów gruczołu mlekowego, to dotyczy suk. Myślę, że to jest dość proste, bo w 3 pytaniach odpowiadamy sobie na wszystkie kwestie dotyczące tego, co robić z guzem gruczołu mlekowego. Jeżeli mamy guz gruczołu mlekowego, to nie pytamy, czy operować, tylko pytamy, kiedy operować. Jeżeli guz jest operacyjny, to powinniśmy go usunąć. Za chwilę jeszcze porozmawiamy o czynnikach rokowniczych. Zobaczą Państwo, że to naprawdę ma znaczenie. Wielkość ma znaczenie tym razem. W związku z tym pierwsze pytanie brzmi, czy możliwa jest chirurgia. Jeżeli chirurgia jest możliwa, to trzeba takiego pacjenta zoperować po prostu najzwyczajniej w świecie. Ten pogląd mówiący o tym, że nie należy operować guzu, bierze się z tego, że operuje się guzy po prostu duże, wyhodowane. Mam nadzieję, że Państwo nie będą hodowali guzów. Drugie pytanie, czy margines chirurgiczny po zabiegu operacyjnym jest czysty? Czy usunęliśmy całość komórek nowotworowych? O poszczególnych zabiegach nie będziemy dzisiaj mówili, bo to jest oddzielna kwestia. O szerokości, to się nazywa surgical dose. Nie ma dobrego polskiego określenia tego sformułowania. Zasięg zabiegu chirurgicznego, tak można by to przetłumaczyć, jeżeli chodzi o dokładne znaczenie. Nie będziemy o tym mówili, natomiast zawsze staramy się uzyskać czysty margines chirurgiczny, bo to oznacza, że usunęliśmy zmianę w całości. Jeżeli nie uzyskaliśmy czystego marginesu chirurgicznego, to pytanie, czy możliwa jest reoperacja? Najczęściej jest możliwa. W związku z tym, nawet jeżeli mają Państwo naciekanie powłok, czy naciekanie, oczywiście rokowanie jest gorsze, ale jeżeli mamy naciekanie, to jesteśmy w stanie najczęściej usunąć głębsze warstwy, więc zazwyczaj reoperacja jest możliwa. Pytanie o chemioterapię. Myśmy kiedyś spierali się o znaczenie chemioterapii zarówno u suk, jak i u kotek i tak naprawdę ten spór nie został rozstrzygnięty. Niewiele wiemy jeszcze na ten temat, bo tych wiadomości jest mało. To pewnie będzie pytanie na któreś następne spotkanie. Jeżeli margines był czysty, to pytanie brzmi, czy są negatywne czynniki rokownicze, które powodują, że ta pacjentka, najczęściej pacjentka, ma złe rokowanie. Jeżeli ma złe rokowanie, na przykład istnieje zajęcie, co oznacza naciekanie naczyń limfatycznych, proszę Państwa? oznacza, że komórki prawdopodobnie rozprzestrzeniły się w organizmie, bo trudno jest oczekiwać, że komórki dostały się do naczyń limfatycznych i nie popłynęły dalej. Naiwnością jest sądzić, że one nie popłynęły dalej. Oznacza to, proszę Państwa, że jeżeli brak negatywnych czynników rokowniczych, nie brak, czyli są. Jeżeli mamy którąś z tych opcji, i to są te negatywne czynniki rokownicze, będziemy o tym rozmawiali, to oznacza, że suka ma przed sobą krótkie życie. To oznacza, że spodziewamy się, że ten guz da przerzuty. I to są kandydatki do leczenia uzupełniającego. Znowu, chemioterapia ze znakiem zapytania, dlatego że dowody naukowe u suk są stosunkowo słabe, a przynajmniej kwestionowalne. Natomiast jeszcze pewnie tutaj moglibyśmy dopisać terapię, znaczy leczenie antyangiogenne, ale to pewnie kiedyś następnym razem o tym sobie porozmawiamy. Jeżeli natomiast wszystko jest ok, nie ma negatywnych czynników rokowniczych, to kontrole kliniczne. Taki sam algorytm mamy dla kotek, natomiast u kotek proszę zobaczyć, jak wygląda wybór tak zwanych surgical dose, czyli zasięgu zabiegu chirurgicznego. Proszę zobaczyć, że mamy tylko dwie opcje. Hemimastektomia albo mastektomia totalna. Udowodniono, proszę Państwa, że zrobienie u kotki mniejszego zabiegu niż hemimastektomia pogarsza rokowanie dla pacjentki. My staramy się, jeżeli mamy pacjentkę w dobrym stanie, staramy się zrobić 2 hemimastektomie. Dlatego, że tam będzie taki slajd o czynnikach rokowniczych, to powiem o tym. Reszta jest bardzo podobna. Trochę inaczej wygląda sytuacja tutaj z bardzo prostego powodu. U kotek guzy gruczołomlekowego zazwyczaj są znacznie bardziej agresywne niż u suk, dlatego więcej kotek po pierwsze kwalifikuje się do leczenia uzupełniającego i proszę zobaczyć, że tutaj nie ma znaku zapytania. Innymi słowy, mamy dość twarde dowody naukowe, że chemioterapia wydłuża życie kotek z negatywnymi czynnikami rokowniczymi. I tutaj nie mamy wątpliwości, że kotki odnoszą korzyść z chemioterapii. Generalnie co najmniej 5 dawek chemioterapii. Wiem, że mam szybciej mówić.
No właśnie i wiemy też, że guzy, to jest udowodnione, guzy listwy mlecznej są zależne od hormonów. Mnóstwo prac, mnóstwo publikacji. U suk 40-70 nawet procent komórek nowotworowych ma receptory estrogenowe lub estrogenowe i progesteronowe i zwiększa ryzyko wystąpienia łagodnych guzów, ale i złośliwych też, stosowanie gestagenów. Już coraz rzadziej te gestageny są stosowane, ale wiem, że jeszcze są stosowane. No i jakie jest rokowanie? Rokowanie zależy od wielu czynników. Jeżeli są to guzy łagodne, poniżej 3 cm, dobrze odgraniczone, nie ma zmian węzochłonnych, są to nowotwory nabłonkowe, przewodzikowe i z niskim agnorem, rokowanie jest dobre. Jeżeli są to nowotwory złośliwe, powyżej 3 cm średnicy, naciekające, są zajęte węzochłonne, są to nowotwory mezenchymalne, wrzodziejące, z wysokim agnorem, no to rokowanie jest słabe. Ale dodatkowo pogarsza rokowanie ilość guzów, wiek, im starszy, tym gorzej, rodzaj zabiegu, im bardziej oszczędzający, masa ciała i ogólna kondycja.
To nie jest takie proste, mówiąc bardzo szczerze, tak mi się wydaje. Po pierwsze, ja agnoru nie robię, to jest obszary srebrochłonne jąderka, ale tego nie robię. Natomiast państwo, praktycznie rzecz biorąc, podejdźmy do tego praktycznie, państwo dostają wynik od histopatologa, który państwu pisze, jaki guz państwo usunęli, prawda? I na podstawie tego czynników rokowniczych państwo muszą podjąć decyzję, czy ta pacjentka kwalifikuje się do leczenia uzupełniającego, czy nie. Czy wystarczy chirurgia, którą państwo zrobili dobrze, z czystym marginesem. Mają państwo tutaj, zebrałem różne guzy, to jest po stronie, którą właśnie pan doktor Hildebrand zasłania. Jakby mógł się cofnąć ze sceny, to byłoby dobrze. Proszę Państwa, mają Państwo zebrane różne guzy gruczołu mlekowego. Rokowanie pogarsza się w miarę schodzenia niżej na tej liście, proszę Państwa. Generalnie przyjmuję, że jeżeli mam raka litego, to zastanawiam się, jakie są inne czynniki rokownicze, bo raki lite, proszę zobaczyć, solid carcinoma, median survival time, czyli mediana czasu przeżycia po zabiegu operacyjnym 8 miesięcy. Nie za dobrze już. Wszystko, co jest poniżej raka litego, to jest już negatywny czynnik rokowniczy, proszę zobaczyć. To ma znaczenie, bo to Państwa właściciel będzie pytał i co dalej. Kobiety uzyskują niewątpliwą korzyść kliniczną z chemioterapii. To wiemy na pewno od wielu lat, szczególnie w rakach nie mających receptorów. Są takie raki trójujemne, które fatalnie rokują i tam tylko chemioterapia działa, nie działa terapia celowana. Proszę Państwa, te wszystkie rzeczy są negatywnymi czynnikami rokowniczymi. Innymi słowy, od solid carcinoma zaczyna się rozmowa o ewentualnym leczeniu uzupełniającym. Poproszę następny slajd. I tutaj mają Państwo inne czynniki rokownicze, w tym również czynniki rokownicze tyczące kliniki, bo proszę zobaczyć, patrzymy, czy guz szybko rośnie, po drugie, jaką ma wielkość, po trzecie, nacieka, czy jest nieprzesuwalny, bo co oznacza nieprzesuwalność? To jest inwazja po prostu najzwyczajniej w świecie. Dalej owrzodzenie guza, proszę Państwa, to jest negatywny czynnik rokowniczy, kliniczny i powiększenie węzłów chłonnych. I teraz mamy TNM, oczywiście, wiadomo, im bardziej zaawansowany guz, tym gorzej, ale proszę zobaczyć, jak wygląda mediana czasu przeżycia w guzie owrzodziałym i bez owrzodzenia. Widzą Państwo różnicę? Bardzo znaczna różnica. To wszystko ma swoje uzasadnienie w badaniach. Nie umieszczałem tego, żeby Państwa nie zamęczać. Myślę, że że to będzie dla Państwa wartościowe, bo na podstawie tego podejmujemy decyzję kliniczną. Czy pacjentka się kwalifikuje do dalszego leczenia? Proszę Państwa, pierwsza rzecz, na którą jeszcze musimy zwrócić uwagę, stopień złośliwości histologicznej, proszę Państwa. Śmierć z powodu guza gruczołu mlekowego G1 to jest 0%. Tak naprawdę nie zdarza się dalszy ciąg. Śmierć z powodu guza gruczołu mlekowego G2, drugi stopień pośredni złośliwości histologicznej, czyli grade, to jest 15,8%. Ale czy widzą Państwo, jaki jest odsetek śmierci z powodu guza G3? 58,8%. Co to oznacza? Że suka, która ma raka litego G3, ma 60% szansy, że umrze z powodu tego guza. To jest pacjentka do chemioterapii albo do leczenia uzupełniającego. To samo, proszę zobaczyć, jaka informacja, to jest krzywa przeżycia Kaplan-Meiera. Krzywe przeżycia. Proszę zobaczyć, jak wygląda czas przeżycia dla pacjentów, którzy mają inwazję naczyń i pacjentów, którzy nie mają inwazji naczyń. Informacja od patologa, zajęcie naczyń chłonnych oznacza, że ta suka na krzywej przeżycia gwałtownie będzie spadała.
Oczywiście są też wady gonadektomii i o tym wiemy, bo sam jestem właścicielem suki labradorki, która nie trzyma moczu po gonadektomii i jest cały czas na lekach, które niwelują ten efekt. Na pewno w wieku poniżej 6 miesięcy, poniżej 12 miesięcy jest wpływ na zdrowie stawów i to też jest udowodnione. To zwłaszcza dotyczy suk ras dużych. Poza tym też udowodniono, suki, zresztą samce też, otyłe mają, po gonadektomii mają większą skłonność do otyłości, do niedoczynności tarczycy, do nadczynności nadnerczy, niektórych chorób immunologicznych. To jest udowodnione. No i zdarza się, że kastrując suki z powodów behawioralnych, jeżeli to nie jest tak naprawdę rozpoznane, że to jest wpływ hormonów, i my taką sukę wykastrujemy, to pozbawienie jej tych hormonów czy samca może nasilać jeszcze agresję w stosunku do najbliższego otoczenia, w stosunku do członków, w stosunku rodziny, w stosunku do zwierząt, które są razem. Ponadto sterylizacja czy gonadektomia wykonana przed okresem dojrzewania może zwiększać ryzyko nawracających infekcji dróg moczowych, dróg moczowo-płciowych, no w tym sromu. To są takie rzeczy oczywiste. Mniej oczywiste jest to była twoja kwestia.
O, tak, dobrze. Proszę Państwa, pojawiły się badania mówiące o tym, że gonadektomia zwiększa ryzyko wystąpienia innych nowotworów, nowotworów spoza układu rozrodczego, czyli nowotworów nie jajników, nie macicy, nie pochwy, nie gruczołu mlekowego i dowodów na to jest coraz więcej. Natomiast trzeba zważyć tak naprawdę, jaka jest skala problemu, myślę, i spróbujemy to zrobić. Takie dowody dotyczą nowotworów, które Państwo mają tutaj. My nie będziemy się nimi zajmowali, natomiast na koniec sobie spróbujemy to ocenić. Dotyczą nowotworów układu moczowego, kostniakomięsaków, chłoniaków, naczyniakomięsaków. Tam jest tego dużo więcej. Na końcu będą Państwo mieli tabelę, będziecie Państwo mogli to sobie ewentualnie sfotografować, bo tego jest za dużo, żebyśmy to omawiali teraz. To, na czym się opieramy od zawsze, to jest moja kwestia. To jest to, że
Ale
slajd jest mój, to ja robię takie fajne kolory.
Jednak
To jest dowód na to, że faceci rozpoznają więcej kolorów niż 3.
jaki to jest kolor? To, że rozpoznaję, to znaczy, że umie go nazwać. Wiadomo, że jeżeli wykonana jest sterylizacja przed pierwszą rują, ryzyko zachorowania na nowotwór listwy mlecznej w stosunku do suk sterylizowanych spada do 0,5%. Jeżeli sterylizujemy suki między pierwszą a drugą rują, to ryzyko spada do 8%, jeżeli pomiędzy drugą a trzecią rują do 26% tylko.
No tak, fajnie, tylko proszę zobaczyć, jaka jest data tego badania. 1969 rok. Widzą to Państwo? I teraz, proszę Państwa, od 1969 roku mamy te dane i tak naprawdę niewiele więcej. Czy zaufaliby Państwo ludziom z 1969 roku?
Jeszcze słowo i...
Tak. On jest oczywiście starszy ode mnie, mnie w 1969 roku nie było, a on już był na świecie. Proszę Państwa, i tak naprawdę, jak weźmiemy pod uwagę wszystkie dowody naukowe, nie będę omawiał tych wszystkich rzeczy, nie będę Państwa męczył, pojawiły się po 1969 roku badania, które mówią, że sterylizacja czy kastracja, gonadektomia, bo chodzi nam głównie o hormony. Gonadektomia nie wpływa na częstość występowania guzów gruczołu mlekowego i tak naprawdę ten entuzjazm nieco przygasł. Natomiast proszę zobaczyć, jakie były grupy badawcze. Tam było 170 psów w całej grupie badawczej, 140 psów to mało. Jest jedno badanie, gdzie jest ponad 2000 psów, natomiast to było badanie, które zrobili histopatolodzy. Nie o to chodzi, że... Jak nazwać histopatologię? Dobra, nie będę robił wycieczki. Proszę Państwa, chodzi o to, że dane w tym badaniu były niezmiernie zróżnicowane. Wynik z tego badania brzmi, nic nie można powiedzieć. Innymi słowy, no okej, można zebrać, tylko nic z tego nie wynika. To oznacza, że to dowody tak naprawdę były dość słabe. My się opieramy cały czas na tych wszystkich, na tym badaniu z 1969 roku, proszę Państwa, ale to jest z 69... Ile to jest lat? Ile masz lat?
Dużo.
Dobra, idziemy dalej. A to jest taki dobry moment, żeby mu dokopać.
Tylko jest jedno założenie. Większość tych publikacji, na które się powołuje Darek, no zakłada, że psy, które są niesterylizowane, żyją krócej, a te sterylizowane, te sterylizowane mają większą szansę na nowotwór, prawda? Problem jest w tym, że te sterylizowane żyją po prostu dłużej. A im dłużej żyją, tym większa jest szansa, że zachorują na jakąś chorobę nowotworową, bo jest dłuższa ekspozycja na czynniki rakotwórcze.
Lata lecą.
No zgadza się. Tak więc też nie da się tego tak zrobić. Poza tym badania kohortowe w przypadku ludzi, w przypadku onkologii, badania, czyli na dużych grupach ludzi, to są badania, czytamy w literaturze, przebadano 30 000 pacjentów, prawda? My, jeżeli chodzi o weterynarię, to jak mamy 300 pacjentów, to mówimy, że to jest badanie kohortowe. Także zobaczcie, skala skali i też punktu odniesienia.
No tak, proszę Państwa, ale w 2021 i 2022 roku pojawiło się badanie, które jest po pierwsze, dwa badania. Te dwa badania dotyczyły tej samej grupy psów, te dwie publikacje, które to badanie zebrało dość dużą grupę, bo jak Państwo widzą 625 suk. Naprawdę już porządna grupa, prawie 1500 nowotworów, guzów. A więc no już takie badanie, które daje nam coś i wnioski, ja zebrałem te wnioski w bardzo prostych sformułowaniach, nie przedstawiam Państwu tabel, mogę to zrobić, jeżeli Państwo chcą, ale obawiam się, że co Państwo robią w niedzielę wieczorem? Mają Państwo co robić w niedzielę wieczorem? Mogą Państwo posiedzieć tutaj. Ja zajęcia dla studentów dobrze organizowałem w sobotę wieczorem, bo co ma robić student w sobotę wieczorem? Proszę Państwa, wracając do meritum. Po pierwsze, duża grupa i okazało się, proszę Państwa, że suki sterylizowane częściej mają nowotwory złośliwe niż niezłośliwe. Ale to jest logiczne, bo jak odcinamy stymulację hormonalną, to jest mniejszy odsetek nowotworów niezłośliwych. Więc wniosek z tego badania jest taki trudny do zaakceptowania. Po drugie, nowotwory u suk sterylizowanych miały wyższą złośliwość niż u suk niesterylizowanych. To wynika z tego, że tam był większy odsetek nowotworów, które nie mają receptorów estrogenowych, progesteronowych i dla HER2. U ludzi najgorszym nowotworem sutka to jest tak zwany rak trójujemny, czyli rak, który nie ma receptorów. Innymi słowy hormonoterapia, innymi słowy terapia celowana ma mniejsze szanse uchwytu. Następna rzecz, proszę Państwa. Udowodniono, że im większy guz, tym większa szansa, że to jest nowotwór złośliwy. To bardzo logiczne, bo im większy guz, tym dłużej jest ten guz, a więc większa szansa, że dojdzie do kolejnej mutacji, która spowoduje, że nowotwór jest bardziej agresywny. To się wiąże jeszcze z taką teorią kontinuum, ja zaraz o tym powiem. Wniosek, proszę Państwa, z tego bardzo, bardzo prosty. Usuwaj guzy. Nie czekamy, aż guz będzie dostatecznie duży do chirurgii, tylko powinniśmy go usunąć, dlatego że im większy guz, tym większa szansa, że jest to nowotwór złośliwy. I coś, co jest dla nas najistotniejsze. Udowodniono, że sterylizacja zmniejsza ryzyko występowania guzów gruczołu mlekowego, to jest jedna rzecz, i zmniejsza ryzyko występowania guzów mnogich. I jeszcze jedna ważna rzecz, późna sterylizacja nie zapobiega nowotworom złośliwym, ale znacznie zmniejsza ilość nowotworów niezłośliwych, co jest również pewną korzyścią kliniczną dla naszych pacjentów. Teraz pytanie, którzy pacjenci uzyskają korzyść kliniczną? W tym badaniu okazało się, że korzyść kliniczną ze sterylizacji uzyskują głównie suki z guzem gruczołu mlekowego G2, rakiem gruczołu mlekowego G2, czyli drugi stopień złośliwości, i te suki, które mają dużo receptorów estrogenowych albo wysoki poziom estradiolu w surowicy. A więc to jest logiczne, prawda? Bo to są ci pacjenci, którzy reagują na hormonoterapię, a sterylizacja jest w pewnym sensie hormonoterapią. Co jeszcze? I teraz pojawiło się, proszę Państwa, badanie, z którego jest roku, nie widzę dokładnie, 2022. Badanie, które na 225 sukach. No, mogłoby być więcej, ale okej. I proszę Państwa, okazało się bardzo wyraźnie, porównano dwie grupy pacjentów. Suki, u których wykonano tylko mastektomię i suki, u których wykonano mastektomię plus owariektomię. Czyli to, o co nam chodzi. okazało się, proszę Państwa, że suki, u których wykonano wariektomię, żyły znacznie dłużej. This is free survival, czyli czas wolny od choroby. Suki, u których wykonano owariektomię, żyły znacznie dłużej niż suki, u których nie wykonano owariektomii. I jest to twardy dowód naukowy, była bardzo wyraźna znamienność statystyczna. I to jest aktualny 2022 rok, dowód na to, że wykonujmy sterylizację takich suk przy usuwaniu guzów gruczołu-mlekowego. Dlaczego im większy guz, tym większa szansa, że jest to nowotwór złośliwy? Ano dlatego, proszę Państwa, że na bazie nowotworów łagodnych, niezłośliwych powstają nowotwory złośliwe. To jest taki koncept, nie będziemy tego tłumaczyli. Ważne jest to, że trzeba pamiętać o tym, że jak mamy guz niezłośliwy, bardzo możliwe, że w ciągu roku, 2 lat powstanie tam nowotwór złośliwy. Innymi słowy, nie hodujemy, pierwsza rzecz, nie hodujemy guzów gruczołu-mlekowego. Drugi wniosek, nie robię biopsji cienkoigłowej guzów gruczołu-mlekowego, żeby sprawdzić, czy nowotwór jest łagodny, czy złośliwy, za wyjątkiem podejrzenia raka zapalnego. To jest jedyne wskazanie do biopsji guza gruczołu-mlekowego. W związku z tym nie robię biopsji guzów gruczołu-mlekowego, no chyba że jest to mastocytoma, bo mieliśmy taki przypadek u rzecznika kiedyś.
No a co w takim razie, jeżeli już tyle poświęciliśmy czasu samicom, co z samcami?
No właśnie, co z jądrami?
No właśnie, co zrobić z tymi jądrami? Bo co się okazuje, kastrowane samce mają prawie 4-krotnie wyższe ryzyko rozwoju raka znabłonka przejściowego, pęcherza moczowego. Jeżeli chodzi o dane takie duże, statystyczne, to mówimy tutaj o szwajcarskim rejestrze nowotworów. Proszę Państwa, kilkanaście lat temu dr Jagielski próbował w Polsce zorganizować taki polski rejestr nowotworów, no ale nie udało się, nie dostał grantu.
No właśnie mówi to o tym, żeby podkreślić moją porażkę.
Nie, mówię o to, żeby podkreślić twoje zasługi. Szwajcarzy mają taki rejestr już obejmujący lata, popatrzcie, 1955 rok. I co się okazało, że u samic wysterylizowanych ryzyko rozwoju hemangiosarkomy było od 1,6 do 2,2 razy wyższe niż u samic niesterylizowanych. Tak
Mówimy
więc,
o jądrach.
dobrze, ale to akurat mówimy o HSA. Natomiast jeżeli chodzi o jądra, to jeszcze dodatkowo wpływ, ochronna rola testosteronu na prostatę.
No właśnie. To jest ten bolesny punkt, który nawet w mojej praktyce spowodował, że niektórzy właściciele psów z rakami prostaty mieli pretensje do lekarzy weterynarii za kastrację psa. Dlatego, że udowodniono, że kastracja zwiększa ryzyko raka prostaty. I to jest fakt udowodniony w kilku badaniach. Problem polega na tym, że raki prostaty zdarzają się kilkudziesięciokrotnie rzadziej niż raki jąder
No właśnie.
chociażby.
Dokładnie, a poza tym przede wszystkim u psów mamy problem z przerostem prostaty i z zapaleniem prostaty. Problem przerostu, zapalenia prostaty to jest taki problem, problem raka prostaty to jest taki problem, to nie ludzie.
No, ludzie też mają problem.
tak,
Myślę,
nie
że
wiem, czy
wielu z
państwo
Państwa
wiecie,
będzie miało wielkie prostaty kiedyś.
Nie wiem, czy Państwo wiecie, ale zachorowalność na raka prostaty u mężczyzn w wieku 90 lat i więcej jest 100%. Są badania, które udowadniają, że aktywność seksualna zmniejsza ryzyko nowotworu prostaty.
Fantastyczne badanie.
Ale badania amerykańskie udowodniły, że musi być przynajmniej 21 ejakulacji w miesiącu.
Wiadomo, że Amerykanie są crazy.
Proszę Państwa, mimo wszystko są zalety gonadektomii u samców. U samców, u kocurów, bo zapobiega to chorobom, chorobom jąder przede wszystkim. Jest przede wszystkim wskazana gonadektomia u wnętrów z dwóch powodów. Po pierwsze, takie psy powinny być eliminowane z hodowli, bo to jest cecha, która jest przekazywana. Dwa, jądro, które zostanie w powłokach brzusznych, tam jest wyższa temperatura, sprzyja powstawaniu guzów nowotworowych, które dają objawy w postaci sertyliomy, prawda? To już wszyscy Państwo wiecie. Przy łagodnym rozroście gruczołu krokowego jak najbardziej jest wskazana. W przypadku gruczołów okołoodbytowych, nie zatok przedodbytniczych, ale gruczołów okołoodbytowych, Państwo wiecie, jest jak najbardziej wskazana, jest metodą leczenia. Przy wypadaniu cewki moczowej jak najbardziej. Przy przepuklinach kroczowych jest wskazane. Przy zachowaniach, które są zachowaniami dominacyjnymi, wynikającymi z wysokiego popędu płciowego, wynikającymi z wysokiego stężenia testosteronu. Jeżeli mamy wątpliwości, czy faktycznie to zachowanie, to obskakiwanie i tak dalej, tu nie będę rozwijał, bo i tak już jesteśmy po czasie, muszę zawsze skracać, on gada, a ja później skracam, to możemy dokonać sterylizacji farmakologicznej i zobaczyć, czy są efekty. Tak więc jeszcze u kocurów podobne czynniki jak u psów, zwłaszcza że kocury dużo częściej są zwierzętami wychodzącymi, tak zwanymi pozadomowymi, prawda, wolno trzymającymi się, no to zmniejszenie tych zachowań agresywnych, zmniejszenie populacji, walka z bezdomnością i tak dalej, tu można by mnożyć. Ale wczesna gonadektomia, czy to będzie pies, czy to będzie kot, opóźnia zamykanie nasad kości i to może prowadzić do złamań nasad kości udowej, no i właśnie rozwój niektórych nowotworów.
To ty czy ja?
No,
dobrze, ty.
Moja czcionka. Więc jeżeli chodzi o osteosarkomę, po gonadektomii jest ona dwukrotnie wyższa niż u psów bez gonadektomii. To są badania naukowe. Przebadano w jednym z badań, i to są badania, co prawda, tak powie, że to stare, bo 2002 rok, ale przebadano bardzo dużą grupę psów, 700 rottweilerów. W 86 przypadkach było potwierdzenie osteosarkomy w obrębie kończyn. No i wykazało, że gonadektomia wykonana przed 12 rokiem życia, 12 miesiącem, przepraszam, życia, wyraźnie zwiększa ryzyko rozwoju osteosarkomy. Natomiast
jedna rzecz krótka. Psy kastrowane są zazwyczaj cięższe niż psy kastrowane. W związku z tym mikrourazy przynasad są częstsze u psów o większej wadze. Prawdopodobnie z tego to wynika.
No ale tutaj zobaczcie Państwo sami, dwa badania, jedno 2014, drugie 2015. Nie stwierdzono wpływu gonadektomii na częstość diagnozowania mastocytomy u labradorów. To badania dosyć duże, ale u 400 psów chorych na mastocytomę w Anglii stwierdzono, że u psów wykasowanych diagnoza mastocytomy jest mniej. No i bądź tu mądry. Dwa badania, jedno po drugim. Tak więc to już pokazuje, jak różne mogą być wyniki. Znowuż kolejne badanie. Badanie tutaj z 2013 roku. Samce Golden Retrieverów wykastrowane przed 12 miesiącem życia były 3 razy bardziej narażone na rozpoznanie chłoniaka. Oj, przepraszam. Nie podważa to zalet gonadektomii, o których już żeśmy mówili. Zalet oczywistych, takich jak zapobieganie chorobom narządów płciowych, guzów gruczołu sutkowego, guzów wenerycznych. Mało tego, cukrzyca, Państwo doskonale wiecie, jest wskazaniem do gonadektomii. Czy niektóre, bo to wymaga przebadania, naprawdę problemy behawioralne są też wskazaniem do gonadektomii.
Sytuacja u kotek, jeżeli to badanie jest nowsze, młodsze niż z 69 roku. 69 rok to pradzieje. Proszę Państwa, u kotek ta zależność jest bardzo prosta, to znaczy im młodsza kotka sterylizowana, tym mniejsze ryzyko występowania guzów gruczołu mlekowego. Jak Państwo widzą, zależność jest bardzo, bardzo wyraźna. Ja od wielu lat mam koty i sterylizuję swoje kotki, młode kocięta, albo tuż przed pierwszą rują, albo tuż po pierwszej rui. Jak tylko mogę to zrobić. Ja myślę, że ewentualnie o własnych doświadczeniach porozmawiamy na końcu. Natomiast to jest jedna rzecz. Prewencyjny efekt sterylizacji już po 24 miesiącach jest już bardzo niewielki. U kotek nie mówimy o ilości rui, bo kotki są poliestralne. Jeszcze...
Podsumowując, generalnie usług 50/50, mniej więcej, to już żeśmy mówili. U kotek większość to nowotwory złośliwe.
Ten slajd miał służyć temu, żeby Państwu przypomnieć, że każdy guz gruczołu mlekowego kotki powinien być traktowany jako zmiana złośliwa. Okay? Jest to dużo silniej wyrażone niż u suk.
To już żeśmy omówili, ja znowuż będę nadrabiał. Kolejna sprawa.
Właśnie, kolejna sprawa, korzyść u kotki. To się zdarza na szczęście już coraz rzadziej. Jak ja zaczynałem pracę, co było bardzo niedawno temu, to ilość rozrostów włóknistych gruczołu mlekowego była stosunkowo duża. Państwo znają tą jednostkę chorobową. Proszę Państwa, wiele z tych kotek umierało. Naprawdę, jeszcze i przed erą aglepristonu wiele z tych kotek umierało. W związku z tym to jest realny problem. To był problem, kiedy stosowaliśmy progestageny. To było kiedyś powszechne. W tej chwili ja antykoncepcję to daję bardzo rzadko, szczerze powiedziawszy. To już na szczęście ta era minęła, natomiast sterylizacja daje też nam prewencję tego rodzaju problemów.
Tak naprawdę bardzo przyczyniło się do
Jeżeli
zmiany
chcą Państwo zrobić zdjęcie, to
poglądów. Bardzo zmieniło się podejście i zmiana poglądu nastąpiła po ostatnim wydaniu przez WSAWę takiego przewodnika dotyczącego kontroli rozrodczości u psów i u kotów. Polecamy. To jest publikacja, o której najwięcej może powiedzieć profesor Niżański. Zresztą z tego, co wiem, to właśnie chyba
zaczyna wykład, więc nie są Państwo na jego wykładzie, dlatego że zostali Państwo tutaj, ale polecam pójście na jego wykład.
Profesor Niżański jest z nami tutaj, jak Państwo widzicie. Także polecamy.
Wnioski.
Do wniosków, bo naprawdę już przedłużyliśmy za mocno.
No
proszę Państwa, po pierwsze, kastracja nie jest jednoznacznym czynnikiem ryzyka dla wszystkich nowotworów. Ja uważam, że jednak warto sterylizować, warto kastrować. Oczywiście dotyczy to różnych przypadków. Każdy przypadek tak naprawdę powinien być rozpatrywany indywidualnie. Nie można powiedzieć, że wszystkie psy będziemy sterylizować, że robimy akcję kastrowania wszystkich psów, sterylizujemy wszystkie suki i tak dalej, i tak dalej. Każdy przypadek wymaga bardzo dokładnego rozważenia wszystkich korzyści i wszystkich ryzyk.
Powiedziałeś to 4 razy już.
No, żeby się utrwaliło, ty też się powtarzasz. No właśnie, slajdy też to powtarzają.
Proszę Państwa, wniosek jest z tego taki, że każdorazowo sterylizację, gonadektomię nie traktujmy tego jako zabieg, który po prostu jest zrobiony. Zawsze z właścicielem trzeba go omówić, plusy i minusy. Następna rzecz, uważamy, że gonadektomia pediatryczna nie powinna być robiona, dlatego że te wszystkie dodatkowe rzeczy, o których mówił pan doktor Wojtek, o których mówił Wojtek, są mniej nasilone. I trzecia rzecz, właścicielowi też trzeba powiedzieć o niebezpieczeństwach, bo jak Państwo widzą, one są i mamy coraz większe dowody, że rzeczywiście są, natomiast korzyść, która wynika z przeprowadzenia gonadektomii, jest wielokrotnie większa niż niebezpieczeństwa związane z tym zabiegiem.
Proszę Państwa, czas na werdykt. To
Będziemy
jest
mieli
nasz
takie...
kolejny
Dobra.
sparring. Ja, żeby ułatwić sędziemu rozpoznanie, jaki werdykt dla kogo,
Jezus Maria. Zrobił to, proszę Państwa.
Proszę Państwa, bardzo ciężko będzie ten werdykt postawić. Poczekamy, jak zaraz tutaj jednak się panowie przybiorą. Lepiej późno niż wcale. Super. Proszę Państwa, tak naprawdę, jak już powiedziałem, będzie bardzo ciężko postawić werdykt, a zatem ja proponuję, żebyście Państwo pomogli sędziemu, czyli mnie, i może zróbmy tak. Ja będę Państwa prosił o brawa i o aplauz. Zawodnik numer 1, Wojciech Hildebrand. Versus Dariusz Jagielski. Sprawdzam. No jest. Okay. Słuchajcie, poproszę tutaj pana, panie Darku, panie doktorze, może Darku, Wojtku. Poszedł na remis! A ja, proszę Państwa, jeszcze chciałem powiedzieć jedno słowo, że jeżeli ktoś rzeczywiście chce wyjść jeszcze na wykład profesora Niżańskiego, to on się zaczął 3 minuty temu.
Proszę Państwa, idźcie sobie stąd już.